we've done what? 1, 2, maybe 2 other virtual meetings. We keep them short and sweet. Last year's had a little bit of interaction. We had some breakout sessions. This year's, it's all plenary sessions. So we'll all stay in the same room. What we hope is that you will still ask questions of the presenters. Each presenter has been asked to leave time for Q&A. We do have staff monitoring the chat. So if you're more comfortable or you can't unmute for some reason, and you're more comfortable just putting your question or your comment in the chat, that is fine to do so. But we also welcome you at the end of the presentation, unmuting and just going ahead and asking your question. And so we have 4 presentations for you today. Now, these actually, I guess 5. These presentations were selected by the planning committee, and I want to thank those individuals. Now we'll be sure and recognize everyone here at by the end of the goodness, I have not had my full coffee yet this morning, so sorry, I'm stumbling over all my words. I want to recognize the planning committee members at the end of this meeting, but right now I'll just say that we sincerely appreciate their work. They came together quickly. They provided topics that were of interest for their areas that they represented: newborn screening, public health, clinical genetics. We also reached out to the genetic counseling training programs in our region to invite any student presentations that were in alignment with our work. And so we have cobbled together some what I think will be a very interesting morning and informative. So I'm really pleased with the agenda. Some of the presentation topics, presenters who were suggested will be put on the part 2 agenda for the annual meeting 2022. And you'll learn more about that, like I said, toward the end. And so, so we just had to sit back, enjoy, listen, learn, and I welcome everyone. Thank you. Anne, I'm going to turn it over to you.
Great, thank you. Let me actually turn my video on. Oh, so let's see. Do we want to go back to the agenda for a minute? So we'll just do a run through. So because we had thought that we would give our speakers maximum amount of time, so we're going to do a quick bio for everyone on the agenda. So we'll start. I'll give a quick overview of the recent products that Heartland had developed. And Megan Lyon, for those of you who have been attending this meeting, she's no stranger. She's a friend of ours, and she's been with the American College of Medical Genetics and Genomics for a while, and she's currently the Senior Program Manager of the National Coordinating Center for Regional Genetics Networks. And so that means that she just keep us all in line. And then we are very fortunate to have Dr. Nina Nizar, who is the founder and executive director of the Jensen Foundation. And she's a rare disease advocate and a change leader in the rare disease community. So thank you for joining us. And then we'll also have Mariana Rea, and she is the associate director of programs on Expecting Health. And Mariana is also a genetic counselor with over 15 years of experience in genetics and healthcare and biotech industries. And then, so welcome and thank you for joining us. Telehealth perspective post-COVID, that's a hot topic. So we're very fortunate to have Becky Sanders joining us. And she is the executive director of telehealth services for OPYS Physician Services. And she's had a lot of experience in rural healthcare. And of course, that goes hand in hand with telehealth. And Becky was also previously the program director for the Upper Midwest Health Telehealth Resource Center. And again, thank you for joining us. And last but not least, we have Sophia Griffith, and she has just completed her genetic counseling training. So congratulations, we're very happy and proud. And she will be an oncology genetic counselor for the George Washington University Medical Faculty Associates. So, and then we'll wrap up with Lori, whom you know, with we'll have the coming attractions for next year. And I just like to also mention that we have a longer biography for our speakers, and those will be included with our slide deck when we distribute those after the meeting. So thank you. So we'll go to our next topic, which is I guess we'll be talking about our products. And I'll promise to be short, so because I'm probably the least interesting of the whole lineup. So, but I'd like to highlight a few of the products that we have been working very hard on, and with obviously a lot of input and a lot of work from many of our work groups and experts. Next slide, please. So I just thought I'd put some pictures here, and they so these are some of the representative products that we develop, but it's not all of it. We really have, so again, it's no surprise. Everyone has known over the last 2 years, it's been really challenging, and it's not just us. Many of these federally funded projects that normally rely on a lot of in-person interactions, we've kind of had to repivot and trying to figure out how can we be useful and productive during this time. So, so we have focused on a few of the items that many of our workgroup members have been telling us that we need and should be embarking on. So I will actually start with the easy one, because we've been talking about it for many years, and it's actually yielded a really excellent line of product, and that's in the middle. We have videos in Spanish and Marshallese, and now I've actually kind of lost count. How many do we have now? Like 7. We have one more in the works. So for the Spanish one, so these are kind of screenshots. They live not only on the Heartland website, but they are also on our Heartland's own YouTube channel. I didn't realize that was a thing, but we have our own YouTube channel. So, and this is why I'm not in charge of this. Someone else much smarter is, and a whole group of them actually. So we now we're finishing up video number 5. And then also I want to give a shout out to not just our Heartland folks, but this is really a joint effort. It's the Family Center, it's couple other regional genetics networks, the one in Southeast, New York and Mid-Atlantic, mountain states. So, so that we have, this is a true collaboration, obviously with Acmg and our National Coordinating Center. So we have now 4 videos that are already being slowly released in Spanish in the last couple years. We are finishing up the video number 5. We are working on script for video number 6. So with the goal of finishing this, well, let me not steal Lori's thunder. So, but no, she'll tell you more about video 6. But we now have probably by the end of this month, we'll have 5 videos out there. And then for the one in Marshallese, I think we now have the newborn screening that's been up for a little bit. And then we also have one for Eddie. Let's see, and I think there are more in the works that will be coming. And then, so another one, I'm sorry, I'm jumping around, Care Notebook app. So that is also something that we have reallocated some of our funding to work on this Care Notebook app. So with the goal, and many of you have helped us work on it, give a lot of feedback, and we so appreciate all of that. And so the Care Notebook is ready to be launched. And then that will be all part of our social media campaign, which Lori will talk about at the end. So, but again, thank you all for those of you who have worked really hard to give our collaborators and the app developer a lot of input. So we hope that this is something that will be very helpful and that will kind of take away the need of having to lug around many binders. So that will be forthcoming. And then also I wanted to say that the Care Notebook app, it really was led by our the Heartland's Advocates work group. And there's a sub work group that just dedicated a lot of their time on this. And then we also, so this is the clinical services group that from the last funding cycle, we got a lot of feedback about the need for more knowledge and resources on authorization for testing and composing letters of necessity. So, so this is led by two Genetic counselors, and so Erin Beaver and Julie Kaler, and they have just amassed an incredible amount of resources on the different steps to take for prior authorization and what are the components of a good letter of necessity that will actually help us achieve the goal. And they have delivered a national webinar, and they will actually incorporate some of this information at our, oh, this is a natural segue that I didn't expect, our Project Echo. So we will be having our Project Echo series. So I'm jumping up here. So Heartland actually, all of us, our group got certified to be a Project Echo. So we will be delivering a series of Project Echo education. What do they call it? It's not a webinar, but it's sessions that will be, so the key aspect of Project Echo is as case-based, it's interactional, it's not didactic. We will be actually, and many of you probably have already received some information about this from Kara. So our Project Echo series will be starting actually next Friday, and there will be, and I think there are 3 in the series, and then also we are using the Project Echo format to meet some of the needs, the training and educational needs for our states. So let's see, oh, next, we have the individual healthcare plans that again, our advocates work group had been working on. And so this is, so Emily Meyer, many of you have probably already worked with her on this. So this is a new product that has incorporated more family feedback. This is being translated into Spanish and Marshallese, as with most of the Heartland products these days, they are being translated into these 2 languages. And so we are starting to do family network trainings, and Emily will also collect some qualitative information so that we can continuously improve on this product and get it into our schools and also some of our hard to reach populations. And also I think we are in the process of discussing the developing videos or training videos to accompany the dissemination of IHP. Okay, I think, Lori, did I leave anything out? Okay, then I will turn this over to Megan. We'll have next slide, please. Thank you.
Hi, thank you so much. So I have some slides, if I could share. Thank you. Okay, can everyone see my presentation? Great, thank you, Lori. So thank you so much to Heartland for the invitation to speak today. As Anne said, I have been coming to your meeting for a number of years, and it's always great to see everyone virtually or in person. And today I've been asked to give kind of a tour of the regional system, as well as some updates from NCC. So I'm very excited to be doing that. As a reminder, the the country is split into 7 regional networks. So the 7 regions, the National Coordinating Center for the Regional Genetics Networks, which is who I work for, and the National Genetics Education Family Support Center, all 9 of us work together towards the same mission of improving access to services for underserved populations. And this work really focuses around a couple of core focus areas. So one of the biggest ones is genetics and genomics education, and that's really where my talk today is going to focus on. So I'm not going to go too in depth right now, but our other focus areas are telegenetics. So there's a lot done at the regional level in terms of supporting providers and families to ensure that they can get access to services if they need it via telegenetics. There's also, our whole system has an evaluation component to it that all the regions submit data to NCC, and we provide both internal and external reports about, are we really reaching who we want to be reaching, and are we meeting that goal of improving access to genetic services? And so we have evaluation as a core focus area. And then the national level, we also focus on genetics policy education, which I'll get into a little bit more detail now. But there's also great work that's done at the Heartland around this area that we've tapped into. So I'll talk about that a little bit later, about the great work that we've been able to utilize your all's expertise to help us with our policy education. And over all of those areas really is the families and engaging families in leadership. And so that's why it's not its own little bubble. It really is something that is a part of everything that the system does and is integral to make sure we are working towards our mission of improving access. And so, as I said, really what I'll be focusing on today is some genetics and genomics educational offerings, both at the regional level that you all can utilize, even if it's not within Heartland, and at the national level. And so first we'll go through a tour of the regions. And so we tend to go from east to west when we're talking about the region. So I'm going to stick with that model of starting with the Northeast, or the New England Regional Genetics Network. And so New England, or NERGN as we call them, they have a lot of great tools and resources related to genetics and genomics education. You may be familiar with GEMS, their genetics education materials for school success. This is targeting genetics and the school setting, and working with school nurses and healthcare professionals to really build tools and resources that can help support students. But today I'm going to highlight their new webinar series that just wrapped up in March of this year, and they'll be starting a new one in fall of 2022. And this series really is an overarching look at genetics. So NERGN partners with the Weitzman Institute, which is a community health center that's run out of Connecticut. And these webinars focus on things that are very condition specific, as you can see on the screens, things related to PKU, or it can be very broad about the delivery of genetic services. So they had an excellent webinar on the financial aspects of genetic testing, and there's everything in between. So you can go to their website. All of these webinars are freely available, as well as some of their older series that took an echo-like approach in 2021. So you can find those on their website. So if we go south, we have the New York Mid-Atlantic Caribbean region, or the NIMAC region. So this is primarily, as you can see on the map, the New York Mid-Atlantic area, and they also now include Puerto Rico and the Virgin Islands. So they've been developing a lot of great tools and resources in Spanish, and one of those educational offerings they have that is now available in Spanish as well is their When to Refer to Genetics documents. So they have one for cancer, pediatric, and prenatal. I just showed cancer on the screen, but it really walks a provider through what are the steps that need to be taken, or when should you consider genetics referral when you see these individuals in clinic. And so it's available both in on their website, and as you can see, you can download each as a PDF in either English or Spanish. And these are just really great quick reference guides to understanding more about referrals to those specialties. So then we move further south into the Southeast Regional Network, or the CERN network. So CERN does a lot of excellent work engaging metabolic dietitians and looking at the inherited metabolic conditions. And one of those tools they offer, which is freely available, is their eGENA, or their Electronic Genetic Nutrition Academy. This is a case-based approach to learning. And so each session has a journal club, it has a case description, and has more information about that specific case or that specific condition being discussed. And you can go through and really do kind of a deep dive into specific inherited metabolic conditions through eGENA. And again, this is freely available on the CERN website, and it connects to Emory's website on eGENA. Then if we go west and we actually go up north, we have the Midwest Network, which I know you all work with closely on activities. And so they, again, like everybody else, have a stellar program around education. And so they have NOC Part 4 modules, which they're not currently open right now. Their cohort is ending. They'll have another one later in the year, so that's why I did not highlight that. But you can go and learn more about their NOC Part 4 modules on their website. One educational offering that is up right now for you all to investigate is something that came out of their regional annual meeting last fall, which is increasing access to care through the lens of equity and inclusion. This presentation was excellent, and it really walks you through what implicit bias is and gender diversity. So it's a really unique presentation that we're seeing more and more of, obviously, at the national level, in terms of doing webinars around equity and inclusion. And this is a really good way to, it's a good educational offering to get you to understand more about these areas to expand diversity and inclusion in everyone's work. So then I'll skip over Heartland and go to Mountain States Regional Genetics Network. And I saw that Christy's on the call, so I hope I represent her region well. And so one of the excellent tools that Mountain States has recently published, and they just published the Spanish version of this, is their Red Flags for Genetics document. And these were family identified symptoms and signs to look for that may be an indication of a genetic condition. And so these PDFs are available on their website to download, and you can learn more about these red flags. And then we have the Western States Regional Genetics Network, or Western States. This covers the western part of the country, as well as Alaska, Hawaii, and Guam. And so you may have heard of the Minority Genetics Professionals Network. This was started and continues to be maintained by the Western states, and it has been an excellent program to really look at diversity, equity, inclusion in the workforce of genetics, and how can we expand the diversity of the workforce. As we found, NCC does workforce surveys every 4 years, and we continuously find that there isn't the diversity and inclusion, the diversity of the workforce compared to the population of the country. And so this is, NGPN really is, they have a couple of different missions within NGPN. The first is a mentoring program, so to pair potential or early career professionals with experienced genetics professionals to help them as they advance in their career. But it's also, they have educational offerings that so if you don't want to do the mentoring part, you can join their network and learn more, again, about diversity, equity, inclusion, thinking through the topics of DEI and how it affects everyone's work. And so it's a really excellent resource, and really trying to increase the diversity of the genetics workforce. So I see that there are chats. I just want to make sure that there's, thank you, Christy, for putting that link in there. If there are any questions before I move on to my part, I'm happy to stop and talk about the regions before I move on to NCC. Okay, if not, I will still be here to answer questions if you think of something. So then moving on to some NCC activities. So NCC, as Anne said in the beginning, we work very closely with the regions on coordinating efforts of the system, but we also have our own programs and initiatives that NCC maintains, and a lot of those almost all of those are education focused. So the first one, which you may be familiar with, are the Acmg Actuates and Algorithms. So this is a resource that is maintained and developed by Ncc. If you're not aware of the Actuates, they are a clinical decision support tool for non-genetics providers. And they really started as newborn screening Actuates. So these Actuates are one-pagers to tell providers, okay, you received an out of range newborn screening results. What are the next steps you should take, and what's some information about that genetic condition? We continue to have the newborn screening Actuates, but we have developed Actuates for conditions beyond newborn screening. So in the last couple of years, we've published Actuates on non-invasive prenatal screening, as well as secondary findings. And so we will continue to add Actuates, but the major activity that's been occurring at Ncc over the last year and a half is updating the newborn screening Actuates. As I said, we've started the Actuates through newborn screening, looking at the newborn screening Actuates, and admittedly they hadn't been updated in a number of years, and so our goal really has been looking at those newborn screening Actuates and updating them. And so I'm very happy to announce over the last 5 months, we've updated 14 Actuates, 11 algorithms, published 3 new algorithms, and we will be through all of the metabolic condition Actuates and algorithms hopefully within the next 2 months. And so it will be about 30 Actuates will be updated, and the algorithms will be updated as well. Our next steps will be looking at the hemoglobinopathies, and so that work will start this summer with our goal target of updating all of the hemoglobinopathies Actuates this fall. So please be on the lookout for new updates. The link will not change if you have saved a link to an Actuate. That link will not change. It will automatically update once we have the new content available. So in addition to the Actuates, we also have been developing educational offerings that make it a more active, engaging resource than our one-pagers, which are excellent, but it's just a document. And so one of the things we started to do is develop what we're calling our Knowledge Nugget series, which is an animated walkthrough of a specific Actuate. So we published the spinal muscular atrophy Actuate, the SMA Knowledge Nugget last spring. We just last week published the XALD Knowledge Nugget, and then we will have the MPS1 Knowledge Nugget hopefully by the end of the month. And these knowledge nuggets are available on NCC's website and our Vimeo channel. They are also available if you are interested in getting continuing medical education credits. They are available through the Acmg Genetics Academy. So you'd have to go through Acmg's Genetics Academy to get credit. But if you're not interested in CME, you can go and listen to the videos and learn more on our website. So then another educational offering that we have to thank Heartland for all of their effort over the years in this program, because it would not have been possible without your all's help, is our healthcare interpreter training program. So we work with Cindy Rote, who is a healthcare interpreter trainer, and she has developed 3 curriculum for us. Prenatal and pediatric have been up for about 1.5 years, 2 years, and our autism spectrum disorder curriculum just went up in March of this year. And so those curriculums are freely available on the website, so you can go and explore what those are. We also, in addition to having the curriculum, offer trainings to the regions to offer these healthcare interpreter trainings. And this year alone, we've trained over 140 healthcare interpreters, which has been excellent. And Heartland, again, was a key player in all of that. And so beyond the trainings, we're looking at how can we expand what we're doing with healthcare interpreters. So we will be doing a cancer genetics curriculum. We're currently adapting what was kind of impetus for this project. We're adapting that with the newest materials, and so that curriculum will be available. We're also expanding the number of glossaries that are available underneath each curriculum. So there'll be 5 new glossaries in addition to the 4 glossaries that are currently in each curriculum. And then we're also working with Heartland and a couple of other regions to see how can we better support our healthcare interpreters who have been trained after the training by offering them resources and tools. And so we'll be rolling that out later this year. So then some other educational offerings that for you all to be aware of. The first is our medical necessity webinar. And so I alluded to this earlier in my talk. This is, we're partnering with the Catalyst Center, which is another HRSA funded entity funded out of Boston University. They developed a brief about medical necessity, and we wanted to really make that an active educational offering. And so we partnered with them, and then through you all, we were able to connect with Erin Beaver and Julie Taylor, who's done the fantastic work of the pre-authorization and the letters of medical necessity that are available on the Heartland's website, to develop a 3-part webinar series about medical necessity that is available for CME credit. And so the first webinar was held in April, and that is available on our policy website, which I'll be talking about shortly. The next webinar is actually today at 1 p.m., right when this call ends. So if you're willing, if you want to participate in another webinar, we'd love to see you there. And on today's webinar, actually, Erin will be sharing some of the materials from Heartland and how you can access them. So we're really excited to have that. And then the third webinar will be held June 29th at 2 p.m. As an addition to all the other educational offerings I've talked about, we are working with the American Association of Physician Associates, or the PAs Association, to offer a genetics workshop at their conference next week. So it'll be 4 sessions that range from general genetics to how you take a family health history to direct to consumer testing. And so those webinars, it will be at the live meeting, but then they'll also be available as an educational offering through AAPA. So if you work with PAs who want to learn more about genetics, these sessions will be specifically targeting PAs. And so as soon as they're up and available, which obviously they're not since the live meeting is next week, but once they are available, we'll be sure to share them broadly so that you can access them. And then finally, we're really excited to be announcing that we're working with Acmg to offer a 2-part webinar series for the Acmg evidence-based guidelines. So the first evidence-based guideline from Acmg came out last summer, and we really want to provide an opportunity for providers to really engage and better understand the guideline. And so Ncc will be sponsoring what we're calling 101, which will be targeting the non-genetics providers, and it really will be a high-level overview of what the guideline says. And then the 201, which is sponsored by Acmg, will do a deep dive for genetics providers about what the guideline says. And so those will be starting in June of this year. And our plan is we'll be doing this series every time a new evidence-based guideline comes out of Acmg. So I know I've shared a lot of resources today, not only Ncc, but the regions. And so what Ncc has is our resource repository. So this is actually a live view of our website right now. So you can go to our website and you just scroll to the bottom and you can see the resource repository. So we call it, sorry, I keep scrolling weird. The resource repository, we call it RERE. So RERE has over 550 resources as of this morning in our repository. And how we structure it is we provide what the resource is, who developed it, what topics the resource is discussing, who the intended audience is. And really the key part of this, our resource repository, is that we link out to whoever developed it. So the resource does not live within our repository, and this is to ensure that we have the most up-to-date information about whatever resource is being discussed. So we'll always link to the region, to us, to our national partners, so we put their resources in here, the type of resource, the date it was created, a short description. We also list language of the resource, and if there's anything related in the resource repository, say a PowerPoint that relates to the webinar, would be linked here. And so there's a lot of details in here, which can make it a little bit, we know, challenging to find things. So what's nice about the RERE is you can filter by certain areas to say we wanted to find a resource that was developed by Heartland. So we could select Heartland and it will automatically filter everything out that's not Heartland. You can also do the same thing with sorting. So you can sort, you can say, I want to look at the thing that was most recently developed, and it will sort by either oldest or newest resource. And then finally, say you wanted to find a very specific resource, like, I said the name of the resource today. So you can go in and search the resource. I don't know if it's going to let me on here. The Zoom's a little weird. So you can search, like, say, ActSheet, and you'll find the ActSheet as it comes up. So you can type in exactly what was in today's PowerPoint to find in the resource repository. So in addition to our general educational resources, as I said earlier, NCC, one of our main objectives is to help disseminate information about policy. And so we've developed resources for a number of years around genetics policy education. I'm sure I've talked about it at other meetings with you all, if you've participated in past meetings, like we have our Medicaid database, we have other things, but it was all in disparate systems. It was very, if you wanted to find something that was general or across our resources, you couldn't find it easily. And so what we did was we developed a whole new website that really is all about the search functionality. It's all about finding what exactly you need. So this is, again, a live view of the website. So if I want to search whole exome sequencing, I can hit search, and what will come up is our search page. And you can see we have 10 resources that mention whole exome sequencing, and you can even filter by, I want to look at a policy statement versus proposed legislation. So if I want to look at what's currently being proposed related to this, I can go in and click on one of these resources to learn more about the proposed legislation. And so there's a lot of data in here. So as you can see on this slide, we track over 500 pieces of proposed legislation and regulation. We track information for 54 state Medicaid programs, because we also track information for the territories. And we also, the newest resource that came through the Genetics Policy Hub is our policy areas. So the policy areas are really a one-pager explaining why is a policy concern. So an example is there's a policy area on genetics privacy. The one-pager walks you through why is this, why do you see this in legislation? Why are there policy statements written by national genetics organizations around genetics privacy? So you can understand the concept. And then we also provide links to all national genetics organizations policy statements, so not just Acmg. We link to the National Society of Genetic Counselors, the American Society of Human Genetics, as well as other societies or advocacy organizations such as the American Academy of Pediatrics when they have relevant policy statements to genetics. So you can go really in and explore what are the big policy topics currently being discussed at both the state and federal level. And then finally, we have our general policy resources area. So as I said, we're not the only ones doing genetics policy education. Heartland has a great set of tools and resources. So do the National Genetics, the National Genomics, NHGRI, National Human Genome Research Institute, and many others provide policy resources. And so our general resources page links to all of that, so that we really, hopefully you can find things that are applicable that maybe NCC didn't develop, but that others have, that can help you better understand the genetic policy landscape as it stands today. So finally, in addition to the Genetics Policy Hub and genetics and genomics education work we do, we also run Public Health Genetics Week. And as you can see from my background and on the slide, that is Monday, which is very exciting. So Public Health Genetics Week seeks to raise awareness and celebrate the field of public health genetics. We started this 3 years ago, and I always tell people I couldn't have imagined where it went or where it is now. We have the regions are very involved in it. NCC, almost, I believe every government agency that's pretty much related to genetics has representation on our development committee. We have representation at the state level from membership organizations that all help us develop the week and really try to show the breadth of Public Health Genetics Week. And so this is a very high level overview of the week. I hope it's not too chaotic because there is a lot of information, to the point, as Christy put in the chat, we have an entire website just dedicated to Public Health Genetics Week. And so how the week is structured is around daily themes. So each day has its own theme to help educate providers, professionals, individuals and families, just the general public, on really what public health genetics is. And so the first day is, what is public health genetics? Then we talk about who's involved, what are the partners and stakeholders who make up the system of public health genetics. Then it's a highlight of programs. So for example, the regions and NCC are programs that relate to public health genetics, but there are also things at the community, state, federal, global level related to public health genetics. Day 4 is related to public health screening. So this encompasses newborn screening, but it's just not newborn screening. We also highlight the Tier 1 applications from CDC, non-invasive prenatal screening, and expanded carrier screening. And then finally, we share public health genetics resources. As I said, public health genetics is a very expansive system, and that there are a lot of people that do a lot of great work and develop resources. And so the 5th day is really to help us share that information from all our partners and everybody. And so we have daily themes, which have their own webpage. Each one has its own fact sheet that you can download and share. And then we also have events. And so as you can see, there are a lot of events. We actually have 14 events this year, which is the most we've ever had. So it's excellent to see so many people who want to be involved in this week. And so it really ranges from Midwest Genetics Network is doing 4 events during the week. CDC is doing a webinar. We have 2 events that are targeting students with our work with the University of Pittsburgh School of Public Health. There are a couple of NCC-led events, Baby's First Test, and the National Genetics Education Family Support Center are doing events. And so we really just encourage you to go and explore the website, and hopefully you'll find an event or 2 that you want to participate in. And then there's also, in addition to our events, it is a social media campaign. So we have hashtags for the week, so you can find information on social media. We have daily social media graphics that you can use that relate to each of the daily themes. And I'm very, very excited to announce, I think you're one of the first groups I've announced it to, that we've worked with the Latin American Society for Genetic Counseling, and they have translated the daily social media graphics into Portuguese and into Spanish. And so Portuguese and English are up on the website right now. We are having a technical difficulty with Spanish, like just physically getting it up on the website is nothing to do with the graphics itself. It's just, you know, computers sometimes don't want to do what you want them to do. But by the end of today, the Spanish one should be up on the website. And so in total, I believe there are 40 graphics across 5 platforms. So we develop it for LinkedIn, Twitter, Facebook, and Instagram stories and feed. So there are tons of resources, both in English, Portuguese, and Spanish, to help you disseminate information across social media. And then finally, we have a bunch of activities. So if you don't want to participate in an event, or you don't want to go on social media, we still want you to engage. And so we have a digital escape room that's always really popular this year. It'll be about family health history, because that's kind of our running theme throughout the week, is to talk about family health history. We have puzzles, we have coloring pages. And then new this year, we have a book club. So we collected books related to public health and genetics, and you can go on the website, learn more about what those books are. And if you are on TikTok, we are talking about the books on TikTok. So if you're a TikTok user, please come and follow up Ncc. And so again, I know that's a lot of information. One part of the website I just wanted to highlight to help you all participate in the week is the toolkit. So as I said earlier, there's a lot of resources we developed to help you all celebrate the week, so you can go in and use anything you see. And so if you go down here, you can see These are the daily social media graphics, and if you click this button, it will download a zip file, which will have the Portuguese and English versions. And again, by the end of the day, we will have the Spanish versions up of all of these images you see below, and they're available across social media platforms. So we really hope to see you there at some event or on social media, or even if you'd email us and say, hey, I used something for the week in person. It doesn't have to be virtual. It would be great to see everybody participate in Public Health Genetics Week. And I don't know how much time I use, if I use too much time or too little, but I'm happy to answer any questions, and please feel free to reach out to me or anyone on staff, or follow us on social media if you to learn more about NCC in the regions.
Good job, Megan. Thank you for sharing. You actually have 9 more minutes if you have anything else you'd like to talk about. You did a good job. You wrapped it up quick.
Well, I don't have anything, but if there's anything anyone has questions about, I'm happy to answer them.
I just had a comment, Megan. You know, having been with the regional genetics network structure since the beginning, and there are several people on this call who have also been around since those days, in 2004, it is so impressive, the amount of resources and work. And when you look at it from where we started to where we're at now, what a body of work. You know, some days I just feel like I'm banging my head against a wall, you know, like we're not making any progress. You know, it's so minimal. It's such a, you know, little tiny drop in a big old bucket. But that overview that you gave and focusing on the educational resources, it really said to me, no, there's been a lot of work, and there's a lot of genuine intention to reach these communities and to increase access to genetic services. And we don't want this stuff just sitting on a shelf. You know, we want it to be used. We want it to be out there. So that gave me all the feel goods for today. So thank you, Megan.
Yeah, you're more than welcome. And I completely agree. It is amazing, all of the efforts everyone in the system does. And I always really like when I'm asked to talk about us as a system, because it's always really exciting to look at what we've accomplished. Yeah.
Okay.
Yes.
I have a question.
Yeah.
I saw there's a lot of resources, and I'm just kind of curious and interested to know if you guys been working on some of the Spanish material. Do you have any response from the Spanish community, like sending emails, participate in all these events that you guys have? So do you have any response for the Spanish? I'm asking because we've been talking a lot about how the Spanish community is hard to, because of technology, is hard to get into and learn how to navigate the system. Even myself, I'm learning without one time staying all these events. But for the Spanish-speaking families, what is that response? I mean, they really connect with you? Do you have a data or do you can track if families send an email, call, or I don't know. I'm just kind of curious to know.
No, I think it's an excellent question, and I don't want to speak out of turn because it's mostly the regions that work with families. So I don't want to speak for a region to say exactly what data they have or don't have. But from our conversations with the system, absolutely, there's definitely been outreach to make sure that the materials are appropriate, are what the population needs, and then to be able to do that, there absolutely has to be data back. So I don't know exactly what data points all the regions collect on that specific area, but I do know that there is a very deliberate and concerted effort to make sure that the materials are reaching who they're supposed to be reaching. And in terms of for NCC, this is our first time really doing a bunch of materials in Spanish and Portuguese for Public Health Genetics Week. And so what we will do is we're going to work with the Latin American Society of Genetic Counseling, who did this translation for us, to really make sure that we're assessing it moving forward, so that our hope is to continue to expand our offerings in Spanish and Portuguese and in other languages. And as we do that, we will be getting feedback from users to make sure it's appropriate.
Okay, thank you.
Maria, this is Lori, and you know, I think you asked that $1 million question. Building on what Megan said, I think all the regions have learned how to meaningfully engage with communities. But as you know, Maria, and working even our video projects, now they now span, I mean, Marianne has a team that spans half the country, you know, in terms of bringing people together and getting family feedback. But then what happens? You know, you get the input and you develop the product, and then what happens? And I'm going to be talking a little bit about that at the end of today, about that dissemination, because what I am beginning to see, not that this is, you know, some big revelation, but we have been working so hard to get into communities, to engage, to learn, to put something together, to develop, that it's kind of like our head has just been down in that work. And as we're nearing, we have 2 more years left on the end of this funding cycle. And I'm, you know, it's time, and I've been out in the community. I was in Iowa last week doing work with the Marshallese community, and you know, and what I'm realizing is we have across this country, as Megan has just said, these incredible resources, but boy, do we still have a big job in making sure that they're getting out to the people. They're available, but who knows about them? And we, well, I'm getting into my talk at the end, so I'll be quiet, but but it's a real issue. It's a really important question that you asked, Maria. It's a very important question, and it's one that is certainly on our mind, and that's why I'm going to be talking about it at the end. So
I would like to add that Maria and I also have been talking about precisely this. You know, we have developed these videos in collaboration with, I would say, 50 people from different networks and backgrounds and families, and we're in the process of also kind of evaluating the videos as far as development of knowledge. But access is a big kind of, and that's what I've been talking to Lori, is like we're putting all this work, and now how are we going to get it out there? But not only that, from my perspective, I really like the work done by Carson Smith, the graduate student thesis, is she's also evaluating the effectiveness of this video. And Maria and I have had some discussions on, once a video is out, you know, how do we enhance it and how do we share it? So, and it's not only through technology or what's out there, it's also maybe through some more training of the families using the video. So these are things that we're talking about. I just wanted to share that with you all.
All right, thank you, Marianne. This is Anne. So, this is a perfect end to that discussion just now. And I also just like to, add that with Heartland, and I just want to mention that again, that was an excellent question, but with Heartland, we try to make sure that, and we recognize that not all Spanish speakers are the same. So we do want to make sure that our materials is culturally appropriate and linguistically appropriate and culturally sensitive to the communities that we serve in the Heartland region. Of course, we work with other regions to make sure that they are able to adapt that as well. So with Heartland, a lot of our products, we do focus groups before development, and we do focus group after to get some feedback so that it's a continuously, so we continue to improve. It's really a continuously quality improvement type of process for us. So I just also want to share that with everyone. And so now we're at our next, oh, yes.
And
sorry.
I just wanted to say that, and, you know, back to Maria's comment, you know, we think, we don't know for certain, but we think that 2 events actually helped to distribute the videos organically through through the community. Actually, most of the views on our YouTube on one particular video, or I think it's the chromosomes and genes video, are coming out of Mexico. And we have, what is it, Kara? It's somewhere, it's well over, I think. Well, I don't want to say. Kara will put it in the comments, but it's it is like, if I'll be conservative, 12,000. I think it's actually
close to 15,000, I think. And other all that.
So, and it was we think the 2 precipitating events are Maria Isabel's training in Puerto Rico and the evaluation study we've been doing of the videos themselves. And although that may have involved, you know, 160 some people, the distribution of that back to their families in Latin America was amazing. So anyway, so there is, you know, there are some ways of getting these resources into the community. And we just happen to kind of, in some ways, I mean, Maria's was intentional, but through Carson's work, I think, stumble onto one of those ways. It wasn't planned necessarily, but anyway, I just wanted to add that comment, Ann. Sorry for taking up more time.
Really quickly, it's back to relationships with others. And that's how we've approached various cultures, is through relationships. And this is exactly, I think, what we're experiencing.
Yeah, it is that communication, I think, and because of the pandemic thing, this been putting us behind, you know, a lot of things to get families more involved in actually, I mean, not only that distribution, but also get the feedback and see if the family really understand about genetics and how can I get help and where. So it just, all these 2 years has been really hard for a lot of people, for everybody, I guess.
Yes. Great. Thank you all for this really great discussion. So we are, I'd like to reintroduce, because we did give her brief bio this morning, Dr. Nizar, who is now here to talk to us about navigating the Diagnostic Odyssey. So I will turn this over to you.
Thank you so much for having me. Let me just give me a second. I'm trying to get this set up. All right. Can you see my screen okay?
Yes.
Okay, thank you. Thanks very much for having me here today. I've been listening to the conversation and really applaud all the work that's being done. I think my presentation will come at a timely moment as you have been discussing really what the patient needs, how to involve the patient, how to make sure that the patient understands the importance of, you know, early testing, newborn screening, genetics, all of those really words that you probably use every day in your work. But when we think about patient communities, we think about the jargon that we use and how it becomes impactful for them. So I'm going to talk today a little bit about my own personal experience with the Diagnostic Odyssey. And I'm going to really center around a rare disease, because I have a rare disease and I'm going to talk to you today about Jensen's disease. I'd like to start a little bit by talking about rare diseases and the Diagnostic Odyssey that goes with rare diseases. So as we know, in the United States, there is about 1 in 10 people who are affected by rare diseases. Now, we define rare disease as any disease that affects fewer than 200,000 Americans at any given time. But in order to obtain a clinical diagnosis, what you've been talking about this morning, many patients have to undergo a process that has now been labeled a diagnostic odyssey. And what it means by this is that, we have to go through a process in which we first have to recognize a symptom, right? Or a set of symptoms. And then we need to seek diagnosis from a medical professional. And we may receive an accurate diagnosis, or in most cases in rare disease, we end up receiving an misdiagnosis, which was my case as well. And the average time it takes to actually get a diagnosis for a rare disease patient is 7 years. Now, in my case, it was even much longer, and I'll go into that. But what happens as a result of that? Then patients, caregivers, and clinicians, they begin to face a set of unique challenges. And this is what leads to us calling it an odyssey, because it involves the lack of treatment, the lack of diagnostic innovation, which is integrated into clinical practices. And we then face insufficient clinician education. They're not able to understand what we have. They don't know how to help us. And then what we talked about, what I've been hearing this morning, is access to equitable care. We're unable to get the care that we need to make, even to know. So there is a lack of social capital. There is a lack of knowledge and awareness that there is even an inequity there. Then these challenges lead to a greater emotional and economic burden on the patient, and not just the patient, but the caregivers as well. And as a result, this puts a greater strain on the healthcare system. And if you look at the image that I have here today, I like to always start with this, because I'm also talking a little bit about my particular disease, but I also want to highlight for the audience today, and I know many of you are in this space, but I wanted to show how difficult it is to get not just a diagnosis, but a treatment. And what does that look like? And in most rare disease cases, we are on a mission to not just manage our disease, but we're also sometimes fighting for treatments. And in many cases, it's new treatments. So there are 7,000 rare diseases out there, but only 5% have an FDA approved treatment. So we have to go through almost 8 years of trying to find a diagnosis. Almost 7 to 10 different physicians we will encounter. And then we begin a whole process of learning. The patient is the center, and we continue to learn. And we are the ones who connect to find researchers. We're the ones who push for publications to happen. And then, of course, if we have the social capital and the wherewithal, we are able to start a foundation, a nonprofit for your rare disease, in which you create awareness, education, and give support to the patients that we provide for. If we are lucky and if we are driven, then we can set up a registry to account for the patients within our rare disease. And then we begin a natural history study, which is so important and vital to understanding the phenotype of your disease, and to then begin to plot out points of patient-reported outcomes that the FDA would require. And if we're really lucky, we'll get pharma. If it's lucrative enough, pharma steps in to make a partnership in order to develop your drug and treatment so that it becomes available on the market. And then, as everybody knows, there's a question of, can we then access that drug? So it is, the pipeline to a treatment is layered, and it is filled with obstacles. And I'm kind of wanting to talk a little bit about that today. So when we talk about a rare disease, I want to share my own experience of the Odyssey and what that entailed. I was born in the Middle East, in Dubai, in the 80s. And when I was born, there was no Google. There was nothing that we could go and search for like there is today. And I want to draw on that point because it's extremely important, because even in the information age we have today, there are communities that are siloed out from information because they don't have access to these things. So just imagine they are in miles and miles of desert. They still don't have the ability to access information. They rely on expert opinions when they go to their community centers, when they go to people in their community who they respect and revere. And that's how information is spread to these communities. So if we're targeting, we got to think about my story in the context of what's happening to our communities of color and communities that are on the marginalized area. And I don't mean marginalized just by race, but I also mean marginalized by access issues and barriers. So we had no expert opinions. My parents had no one to turn to. As a result, I was misdiagnosed with polio and then with several different other bone conditions, which were all wrong, and took my parents down several different wrong alleyways. And then I was told for the longest time that, you know, my life would be, you know, prescribed to a wheelchair, and they didn't have any treatments. I still remember being carried up flights of stairs to go to school. My father, who was an engineer, he would lie me on a table and he would tie me to the ironing board because he said her legs are bending and no one's believing him. And this was in the 80s. And of course, I ended up going to school, being carried to school, and my father said you would get an education. So I did. And then, of course, you know, at the time, 30 years later, and I never even knew what disease I had because we just couldn't find out what I had. And then I did go on to get married. And when I did speak with several doctors before, they all told me that I would not have children, that there's no possible way you could have a child. And so we were in the process of actually adopting when I did become pregnant. And in 2009, I had my first son, and his name, we called him Arshan. It's Persian for a strong and brave man. And at this time, there was no sign of disease in him. He was 9 pounds. It was a huge baby, and you know, I had no trouble whatsoever with my pregnancy, and so we were really happy and we were excited. And you know, he had nothing. He didn't look like me. He had nothing of my features or any sign of disease. And of course, you know, as a mom, you're always taking them to the doctor and say, "Are you sure? Are you sure? Can you check this? Can you check that?" And of course, there was nothing. But remember, I was so uninformed. I didn't know what I had, and so I didn't really know what to look for. And every part of my record from my past was, you know, bits of scribbled paper that my father had put together. We don't have access to medical records. That's a huge barrier to understanding your own, you know, prognosis and how your disease can develop. In 2010, I had my second son, and he was, again, born with, at that time, we knew something was wrong with my first son. By the time I was pregnant with my second son, we knew immediately that there was, you know, he started missing his milestones. It was almost like he had reached a point where everything just crashed. And I was pregnant with my second son, and we were like, oh my goodness, you know, we need to find out what this disease is. And I was in Dubai in the time, and I remember resigning my job. I went back to India and with my parents who had retired there, and we were so lost. We were searching for a diagnosis, and I can't begin to explain how difficult it is and how painful it is not knowing what the answer is. So, you know, it was a series of late nights, you know, sending out x-rays, sending out, you know, measuring your kids, measuring every part of their body, describing it in words, and then sending it across the world to see, hey, does this, you know, sound like anything you know? And then we had no idea. But in 2010, when I had almost given up hope that I would ever find an answer, my son was born, my second son, Jahan, and we named him Savior because Jahan means savior in Persian, because he came with a diagnosis. He was a textbook sign of the disease. And we went to a geneticist, you know, the last geneticist on our list that we had to go see. And we walked in and she saw our x-rays and she took one look at us and she said, I think I know what you have. And it was the most earth-shattering moment of my life. It totally turned the trajectory of my journey. She said when she was in Germany studying in a skeletal dysplasia class, her professor showed the class one slide of a Jensen's patient and told the class, we're going to skip this slide because you're never going to come across a patient with Jensen's. But this doctor remembered, the geneticist remembered the slide. And she, as soon as she saw my son's x-ray, she knew what we had and she contacted her professor in Germany. Our blood was sent to America to a doctor who then diagnosed all three of us with Jensen's metaphyseal chondrodysplasia. It's a rare bone disease, it's one of the ultra rare diseases, 30 patients known to date. It is an autosomal dominant condition and it is caused by activating mutations in the PTH-R receptor. And of course it causes lots of pain, skeletal abnormalities, hypercalcemia, nephrocalcinosis, renal disease. And there are just 30 patients known to date, and I couldn't find even one. And so I'm really one of the oldest living adults with the disease right now. And so, of course, my whole mission changed because it became, how can we help my children? I had gone through 30 surgeries growing up. I had a very hard time moving around. I was in hospital a lot. Knowing that that would be the same outcome for my children really spurred me to start the Jensen Foundation and to meet the researcher who had seen our blood but never really knew who we were. This man diagnosed us, Dr. Harold Jupner, when he received our blood. And in 2015, we came to America. We left our lives. We came to America to start a new life and to set up the foundation to find a treatment for this disease. And so Dr. Harold Jupner had been researching the Jensens for 20 years, but he never met a patient. And the first thing he said when he saw me was like, why are you in a wheelchair? And I said, well, because it hurts to walk. And he did never realize that the condition caused such pain and that the boys had gone through so many surgeries. And so this is us at the Rare Disease Institute in NIH in 2016. And then he went on later to meet my boys in 2016 when they went to Delaware to the hospital. We formed the Jensen Foundation in 2017. And we found other patients around the world. Together, we collaborated and published articles with the MGH and Harvard University to publish information regarding the disease because there was not enough publications and understanding of the disease. We talked more and more about children living with this disease, and we made sure that researchers and clinicians and people around the world understood and how could diagnose by looking at skeletal x-rays and pictures and images. We then went to make sure that everybody knew how to care or manage the disease because of my own experience. So we were able to document these conditions. We then began to search for people across the world who had this. And this is again talking a lot to awareness. And how do you create that awareness for a condition that affects less than 30 people? Today we have, and remember, this is 30 since the disease was discovered in 1964. And there were only 30. Today we have discovered across the world 15 patients, and all of them are children, and most of them are in South America or places that don't speak English. And it was really important for us to get the material to these community centers, to places that were in the nooks and crannies of the world that would misdiagnose a child. And therefore we were very adamant that we would publish articles in different languages, bring together researchers from different spheres of the world to understand, even though it was such a small disease. And here are the 5 Jensen's patients in America that are alive today, that we got them together in 2017. We did a lot of awareness for the disease. We had a TLC video. We had a Discovery Channel news story as well. And we documented the condition in several different ways. And then, of course, we went on to publish several research papers on this condition. And today we have a treatment that is now being developed for Jensen's. And you can see some of the findings of it. It's an inverse agonist that is now passing toxicology study at the NIH so that it will become available for patients to use. So with the efforts of understanding your disease, with the efforts of knowing how to treat something, you begin to understand how we can make a difference to even such a small disease as this. So in 2017, we received the NIH grant for preclinical studies for Jensen's. In 2018, we had our first IND with the FDA to get data for this condition. And then in September of 2019, we got another grant, the NCATS, which is the translational part of getting a drug into the market. And in 2022, which is this year, we will have our first in-human protocol approved by the FDA so that children will receive treatment. And so with that, I really wanted to say, no matter how small a disease is, it impacts your life in ways you cannot even imagine. And so it begins a journey, an odyssey that you want to end. And so with genetic testing now, whole genome sequencing, whole exome sequencing rather, it has become so much easier to pinpoint genetic anomalies. And it is so important that more and more people across not just America, but the world begin to have that as an opportunity. And right now, even in Nebraska, I'm not sure that everybody has access where it's covered by insurance to have whole genome sequencing, because as a foundation, we pay for it if there are patients that we suspect has Jensen's and they can't afford it. So, and then we're also working to get it onto our newborn screening panel so that they can be screened for this, and early diagnosis is key to many of our diseases. So that's what I want to end with. I think I'm at time. If there are any questions, please let me know.
Thank you so much for this presentation. I'd like to open up for questions. Thank you again. What a presentation. We really appreciate your sharing this with us. So just feel free to unmute yourselves.
We have some comments in the chat.
Yeah, or questions. Sorry, I haven't gotten to the chat.
Is there an application?
Yes, there is, for any skeletal disease, you have a free exome sequencing that you can do. It's available to anybody in America as well as anyone in Canada. And I'm going to put the link in the chat. And this is for any skeletal condition, or it's just a free toolkit that you can share with anybody. Let me put it in the chat. And it's not just for Jensen's. It's a free exome sequencing that you can share with any patient. Sorry, I have to find it.
No, you're good. Thank you.
Yeah, if there are other questions, please let me know. I'm kind of looking for the link.
There's a lot of thank yous, very impactful. Love your story. Thanks for sharing. So great job. Thank you.
Absolutely.
And thank you so much, Nina. I just wanted to add one more thing when you talked about your journey of coming from Dubai to India, USA, and all this. Actually, last night I met with a group of parents from the Middle East, and they shared their stories being in Egypt and not having those services, any resources, and the way they are now connecting through the internet. I just see so much possibility now with sharing information, translating that, and sharing with families that are all over the world. So thank you so much. Your story was so powerful, like always. Thank you.
Absolutely. Here. And this is for any This is from Invitae. It's a pharmaceutical company, and it provides free. It's a free toolkit. So if you have patients who you work with and they have a rare skeletal condition and they don't know what it is, they can use that toolkit.
Great, thank you. We'll be sure to include a link after when we distribute the materials for the conference. Thank you so very much again for the presentation. I believe now we have a 10-minute break or 5, and we can get up and do a little stretch. And Melissa will do a little countdown on the screen, and we hope to see you back for our next talk. Thank you again for all the speakers we've had so far. It's just been, they've been really great presentations. Again, thank you. All right, welcome back. So next up, we have Mariana Rea, who will be talking to us about prenatal education initiative. So I think I'll hand the control over to you, Mariana.
Wonderful. Can you hear me okay? Great. Thanks, Anne. And thank you so much. Hope everybody got a little bit of a break. I know as we're coming back, not very many of you have your video on. So to kind of pick things back up, I'm gonna challenge you, if you're willing, to turn on your video, because hopefully we've all had enough coffee this morning. But if you're not okay with video, that's fine too. I'm going to do a quick exercise before I jump in. I am probably a new face to this group and to many of you, but I have heard many of your names before and recognize even some of you. So it is a privilege and it is an honor to be able to join you guys today. What a program this morning, and what pressure to kind of kick off the second half of this day. So hopefully we can jump into some really what I hope to be great resources that we can share with all of you around some of the efforts that we've recently launched to really provide education specifically around newborn screening for expecting moms in medically underserved communities. So I'm eager to share that with you today. But to help me kind of focus on some specific points, I'd love to get a better sense of who's in the audience. So real quick, if you have your video on, if you are a family, if you're here representing someone who is a family leader or a family member of someone who has a genetic condition, can you just wiggle your fingers or give me a cue? Awesome. So we have a few families. If you are a healthcare provider of any kind, if you work in a clinic, if you work in private practice, if you work with families, could you give me a little bit of a wiggle? Okay. If you work in public health, if you work with, I know we have different RGN representatives, and I know that's a big bucket. So if you're in that category, maybe give me a little bit of a wiggle. Awesome. Okay, great. So I expected that we would have quite a different group, and that's awesome to see. I probably didn't get everybody. I know I didn't. So feel free in the chat box if I didn't call something out to share. Who are you here representing? I'd love to get a better sense of who is in the audience. Let me bring up, I do have some slides. So hopefully we can get those to load. Are you guys able to see that okay? Perfect.
Yep.
So as Lori and Ann shared earlier, my background is in genetic counseling, and I just wanted to elaborate on that a little bit. I spent a number of years working in both clinical and industry-based settings with a variety of different groups of people across the country. And much of that work has really led me to our organization, Expecting Health, and specifically in work related to newborn screening. So I am passionate about helping families understand and reach, access resources that can help them further understand how newborn screening happens, when newborn screening happens, and most importantly, why newborn screening is such an important public health initiative. And I know that many of you on this call share that passion. So I'm hoping that today we can give you, again, some updates and provide you some additional resources that you may not actually be aware exist because they're relatively new. So quickly, what I'm going to run through, and I do hope to go through slides quickly because I would love to have some discussion at the end of this and answer any questions that you may have. But I do want to just provide a quick overview of Expecting Health. And in that overview, specifically who the Navigate Newborn Screening Program is and what we're focused on specifically around, again, raising awareness and education specifically for expecting moms and in communities that are known to be underserved or harder to reach. We'll talk through some pilot programs that we have completed, and those really highlight through the results that we were able to find and collect there why this type of initiative is so important. And then I will leave you with some challenges and some things to consider in your own work and, in the families and in the work that you all are doing on a day-to-day basis. So many of you may have heard of Expecting Health before, as Megan mentioned earlier this morning, the NCC and many of you in the RGNs partner with the National Genetics Education and Family Support Center, or the Family Center that we love to call it, which is one of the many programs that are managed by Expecting Health. Another program, which I work very closely with, is something that we refer to as the Navigate Newborn Screening Program, or the Newborn Screening Family Education Program, which is a HRSA funded program. So I'd like to start by first thanking HRSA for our partnership and for this funding and collaboration to do this work. We are a 5-year funded program, and we are currently in our 4th year. So much of what I'll share with you today has shaped and formed over a number of years. And we're really excited that in this, what's nearing the end of this grant, we have some really interesting and exciting results to share. Our vision with the newborn screening family education program is truly to create a landscape where all families have equitable access to newborn screening information. And you've heard me say that a number of different times now. This is critical because, as many of you may have experienced in your own personal journeys, when it comes to newborn screening, oftentimes families are not learning about newborn screening until after that screen has happened. And in many situations, it may even be when receiving a phone call about an out-of-range result. And we can probably all agree that that is not the most ideal time for families to learn this information. So through the work of this program and many of the other programs at Expecting Health, we really are focused on reaching all families and reaching all communities in ways that are best for them. So really through meeting families where they are, we want to increase that awareness, those opportunities for education, and really create opportunities as well for families to become leaders and to be a part of the newborn screening system. So all of our program activities really focus on that key piece of meeting families where they are. I will not go through all of our program activities today. There are a lot, but just to highlight that, we, like many of you, implement and utilize a variety of different strategies to try to work with and try to reach families in all different kinds of communities. We do a lot of work through social media. We have a lot of additional resources that I won't share today, but that if you are interested in learning more about or sharing in your own work, I'd be happy, to share those with you at another time. We also reach families, and early on in this program developed a number of online training modules to help families not only learn more about newborn screening specifically, but to further strengthen their leadership skills and to really create, again, training and educational opportunities to develop leaders within the newborn screening system. So if that is of interest to you, we do have those options available as well. But what I'd really like to focus on for the remainder and the majority of this talk is our newborn screening education pilot. And to first set some of that context, I think it's helpful to highlight some of this may not be new, but to really frame why we at the program feel like prenatal newborn screening education is so important, and really what prompted a lot of this work when we were first setting out to develop these pilot programs. As I mentioned earlier, a lot of families don't learn about newborn screening until after that screen has happened. We know that is the way that information is currently received. And that is something that we are trying to change. We also know from different studies and interactions that we've had as a program with families, as well as what's available through other organizations and group, that families share. Families have informed us that when receiving information from a trusted individual like their healthcare provider, that really does improve their overall satisfaction and experience. Many families through many discussion groups have shared on multiple occasions that receiving information before delivery and before having newborn screening is the ideal time to receive this information. And you may already be familiar, but there are even statements from some of the professional societies, specifically the American College of Obstetrics and Gynecology, that really encourage providers in the prenatal arena to share information about newborn screening with their patients during pregnancy. So despite all of this information that prenatal is the most ideal time to share this information, it's just not happening for a variety of different reasons. And so much of this work was really set out to try to start to create models that could potentially shift that current practice. So when we set out to create this pilot program. I've heard Megan and others kind of say this about some of their work too. I think what we thought would start small has already grown into a lot more than what we originally anticipated. But when we originally were thinking about launching a program like this, we really had three main objectives. And the first was to increase awareness specifically around the process of newborn screening and why newborn screening is important for families in medically underserved communities. And the reason that, I know this group is very familiar with working with families of all different backgrounds and communities, but we had actually done some initial research and investigation in the first year to try to get a better understanding of what family needs are around newborn screening education. And from that survey, which included over 500 families responding, we actually were able to see and to quantify that families from medically underserved communities were less likely to be able to identify information and correct information about newborn screening in comparison to families that were not from medically underserved communities. So we know that the access is less in these communities, and we wanted to be able to change that. So we were really focusing in on partnering with communities where we could raise that awareness and education. We also wanted to see if we could assess the knowledge, the baseline knowledge and knowledge after implementing this educational initiative, again, on when and why newborn screening occurs. And our last objective of this work was to create an opportunity for families to be aware of resources, to know where to go if and when they need additional resources around newborn screening, if they find themselves in a situation after screening happens where they may need or want more. So there were a number of key strategies that we really considered initially, and as we continue to scale this work with different groups that we are now expanding and working with. I think one of the first pieces and steps in every group that we are, or with every group that we are working with, is to have a conversation and to really seek to understand what are the cultural perspectives that need to be considered, that we need to be incorporating, and not just through pictures and words, but really what is the language that is being used, and how can we ensure that our materials, resources, workflow, interactions really are representative of the communities that we are doing this work with, and making sure that those communities are a part of and integrated into this process. I've mentioned this already, but really working with healthcare providers that are trusted in the communities has been a very important piece to being able to successfully do this work. And I'll touch on that a little bit more later. We've also really thought long and hard about what educational initiatives are already in place during pregnancy. What do those look like? What is the information that's already being shared? And are there ways that we can incorporate newborn screening education into these workflows and practices that are already in place, so that it makes implementation smoother and a bit easier for the clinical groups and families that are a part of this. We really focused on using practical materials and relatable education materials, really thinking through how do families want to receive information? What works best for these families? Is it in a digital form? Is it in a paper form? And how can we start to assess and ensure that we are truly meeting families where they need us to meet them? And then last, but certainly not least, and I think this ties into all of these things, is really being transparent and building trust. So a lot of when we're implementing this work, we spend not an insignificant amount of time working with different representatives of the community that we're working with to really try to instill and build that trust. So what exactly did we do? And I'll keep this at a high level because I do want to have an opportunity to share a little bit more about the results. So first, we targeted with specific clinics or community groups. We implemented an educational initiative that involved pre and post test questions, as well as participants reading either a digital or a paper form of an informational flip book that covered lots of different aspects of newborn screening. And then lastly, and really where we are now, is that we are sharing this model and this opportunity for prenatal education around newborn screening, and hoping that that model can be implemented and scaled in other places. And as of right now, we've been able to complete this work, or complete a pilot, I should say, in 2 of the 3 communities that you see listed here. Our first was with a community-based high-risk OB group outside of, or in Houston rather. 80% of the families that are seen in this particular clinic are Spanish speaking as their primary and first language. So we developed all of the materials in both English and Spanish, and those are available for other groups if you're interested in seeing those. We also piloted this work with the Plain community, working with a community health clinic in Indiana. And as you can probably imagine, those 2 communities are very different and have very different needs. So thinking through how to share this type of information and education, again, in either paper or digital form, depending on what the needs might be of the communities that we're working with. And we're really excited that we're in the process of working towards an implementation in a clinic located in Oklahoma that is part of the Southern Plains Tribal Health Board. So working with several different tribal ambassadors and tribes in the Oklahoma area to identify a clinic where we can provide this education to families that are a part of tribal communities. I touched on this already, but just to highlight quickly how the actual educational initiative worked in these initial pilot sites. And again, this model was really designed to be flexible. However, in these first 2 sites, what we initially did was share either an information card. For the clinic in Houston, we were in a clinic, so patients were actually roomed and waiting to be seen by their healthcare provider. So while they were waiting in that room, one of the clinic staff shared an informational card with that patient, and that card contained some information about what they would expect in this experience. And it also contained a QR code, which took them to the pre-test set of questions that we asked. We assessed their, it was 10 questions. It was actually 9 questions in the pre-test and 10 in the post. The questions were centered around their feelings about newborn screening and also what they knew already about newborn screening. From there, this was online in the clinic, and it was in paper with the Plain community where we were launching this. From the pre-test set of questions, participants were guided to read the learning flipbook that we had created and designed, which again went through various different aspects of newborn screening. And then finally, after reading the book, families and participants were asked to complete a set of very similar post-test questions. And so from that, we were able to actually measure changes in their knowledge and in their confidence of information around newborn screening from the pre to the post test. This is a snapshot of what that informational card looked like to give you a sense of what patients were experiencing. And I just wanted to quickly touch base on the awareness and knowledge assessments. These were designed in collaboration with a work group that consisted of family representatives, clinic representatives, and various different members of the community that we were initially working with. And so we really took quite a bit of time to really think through what are the questions that we need to be asking to really try to assess, are we able through this initiative and through this experience to improve awareness and knowledge? And we've learned, from the results that this particular tool has been very helpful in allowing us to be able to measure that. The majority of questions were true, false, so they were quite easy for families to answer, and we did include one multiple choice question. This is also a quick snapshot, and we can definitely put this link in the chat box. I will do that when I'm done presenting. That will show you what the actual learning book looked like in its digital form. So if you want to get a sense of that, we would be happy to share that with you. But it's a very brief book. It takes about 2.5 minutes for families to read through. And this is a tool that is available if anyone is interested in using this tool or having this tool available for families that you're working with. We also created different resources for implementation to help ensure that the clinic and the staff that are sharing this initiative have tools and resources that they would be able to use. And in the last couple of minutes, I know I'm running short on time, so I'm going to go through this quickly, but would be happy to come back and answer any questions that you guys may have. But I wanted to just highlight in the initial group, both of the pilots were about 10 weeks in length. And in our first group, we had a total of 56 participants who were able to complete the initiative. And again, it took about 2.5 minutes, and I'll share some of the overall statistics or key takeaways in the next slide after this. In our second pilot program, in our plain community, we had a total of 27 participants that were able to complete both the pre and post test initiative and read the book. And I think the really exciting takeaway is that across the board in both of these communities that we've been able to do this work, we are seeing very significant increases in knowledge and awareness. So I mentioned earlier the specific questions that were included in the assessment focused on key parts of newborn screening and knowledge of newborn screening. So we see in our initial Spanish-speaking group, prior to reading the book, about 32% of individuals out of that 56 were able to correctly identify the definition of newborn screening. And after reading through this book, that number went up to 86%. So we're seeing a huge increase in their ability to correctly identify that definition. And the same is seen in some of the true-false questions that related to the different parts of newborn screening, as well as really understanding that an abnormal newborn screening result does not mean that there is always something, that there is always a diagnosis or there is always something wrong. So really wanting to hone in on what a result of newborn screening really means. And across the board, we saw significant increases in the individual's ability to identify the correct answer to those questions. We saw very similar results in the plain community that we were able to work with. So again, across the board with those questions, we saw significant increases in the individual's ability to correctly identify answers to these knowledge-based questions. And then last but not least, we asked participants to self-report about their levels of confidence. Did they feel after reading the book that they knew more about newborn screening? Did they feel like they knew where to go to access more resources and information? Did they feel capable of talking to their doctor about newborn screening and know what questions to ask? And we saw really positive and amazing results that across the board, there was a significant increase in that confidence, or that most of the individuals and families that were participating in this did feel more confident about that information. We also saw the same in the plain community, with nearly 100% of participants feeling either that they had an increase in awareness, knowledge, or confidence around newborn screening. So to summarize this work and to kind of wrap up, this is one small piece in a very big, big puzzle and a big initiative to really think about how we can bring this information to more families and to more communities. But our hope and our goal with this work is really to start to create a model that can be shared with other prenatal groups and prenatal providers that really can raise awareness and increase knowledge. We've started to see definitely more and more state programs reaching out to us, more clinical programs are reaching out to start to think about what implementing this type of educational initiative could look like in their groups and in their communities. And so we're excited that we have a foundation that can be shared and really resources that have already been developed with various different families and clinical groups giving input along the way. And so, we hope that we can use some of this work to really start to think about how prenatal education can impact the newborn screening system in the long term. And as I said at the very beginning, really try to improve and change the experiences for families as they navigate through this really important process and this really important step in their journey. So with that, I'm going to wrap up. We do have opportunities to connect. As I said, I'm more than happy to share these resources with anyone that might be interested in other resources that the program has available. And this is my contact information, and I'll be sure to put that in the chat box as well. So sorry to go through that pretty quickly. Happy to answer any questions that any of you may have.
Thank you so much, Mariana. This is a very interesting talk. I just realized my earbuds, so I've taken them out. And can you guys hear me okay? All right, thank you. So we will make time for one question. if you have one for Mariana. I am not seeing a question yet. Kara, help me monitor for that. I just want to congratulate you all on this important work. I mean, if this begins to make a difference, you know, so many strategies have been tried around just trying to do better education around newborn screening in that prenatal period. And yet, really until, to my knowledge anyway, really until recently, your work we're doing in the Marshallese population, and perhaps some others, has it really been trying to infiltrate into the medically underserved communities around newborn screening. So this is hard work, it's important work. And it was the ticket, I shouldn't, you know, it was the pathway there. It was the pathway that we used to offer something to the Marshallese community, because we knew that, you know, English speaking women who have regular prenatal care don't know enough about newborn screening. And so, you know, and babies are important to communities, to mamas. And so it's a common thread across no matter what culture, what language. If you can talk about babies, you're going to, you know, mamas are going to be interested. So, all right. Well, let's move on then. Or do we have any questions in the chat, Kara?
We did, and it was answered.
Yeah.
Thank you, Marianne.
Yeah. Discussion around what trimester
Good.
and
Okay.
you know, the work that they've done with midwives. So
Okay, great. We will keep this show moving along then. So it is my pleasure to reintroduce Becky Sanders. So Anne presented part of her bio earlier this morning. Becky and I have worked together for several years now on telehealth training. When Heartland was invited to partner with Midwest region and help them launch their telehealth training, we partnered with the organization, the Telehealth Resource Center, where Becky was working at that time. And so Becky and I have now a several year history of working together. She is a wealth of knowledge around telehealth, and I'm really grateful that she could accept our invitation. She has a very busy schedule, that she could accept and that she was willing to do so. So Becky, we're going to turn it over to you.
Becky, we can't hear you if you're talking. You're muted.
She's getting everything worked out.
You got it. We hear you. Well,
No.
we still can't hear you.
Melissa, it's not on our end.
There you go.
Okay. Yeah. Hang on. All right. How about now?
Yeah, we can. You're good.
All right. Sorry, I'm having some computer difficulties. I've gotten kicked off a couple of times here. And you probably see a really, you see all kinds of messy stuff on my screen, I'm sure. Is that true?
That's true.
Okay. Apple sometimes does weird things. All right. How about that?
Perfect.
All right. So thank you, Lori. I'm honored to be able to do this for you guys. And I'm going to and thank you to our last presenter, Mariana, for trying to get you guys a little bit more involved. So I kind of got a feel for who you are as individuals, what roles you play. But I want to see, some hands or some reactions. Who has, as a patient yourself, been involved in a telehealth visit over the last couple of years through the pandemic? Anybody? Yeah, I see a couple hands. Anybody else? That's it? Oh my goodness. Okay, there's a reaction. Okay, a couple in the chat. All right. So prior to the pandemic and COVID-19, a lot of people, general people that didn't work in healthcare, they had no idea that this thing called telehealth existed. And it's really come to the forefront with patient experiences now. And now we're seeing more telehealth in the mainstream. I follow a lot of different newsletters and updates. So just about every day I'm seeing some article about telehealth. But this particular report from CMS really tells a huge story. So in 2019, prior to COVID, 840,000 visits were done or claims were submitted via telehealth. And this is Medicare information. And then in 2020, during COVID, we saw 5.27 million, and again, this is Medicare visits via telehealth. And I've got that URL there if you want to take a look at that. So exponential increase. I've heard terms, in all telehealth claim lines over various insurance companies, the commercial insurance, Anthem, Blue Cross, Aetna, United, all of those, and Medicaid and Medicare, 4,000% increase. But this one really sticks with me. So we're hearing a lot more about care from home. And this is one of the wonderful advantages that COVID brought to us that we hadn't seen before, where both Medicare and Medicaid removed their barriers, either geographic barriers or what they call location barriers. Many Medicare, Medicaid usually had restrictions around where the patient could be and where the provider could be during that telehealth visit. And prior to COVID, it was really just the cash pay, and sometimes, larger insurance companies that would allow the patient to have a visit from anywhere. So this has helped in many cases that pay for that reimbursement for providers to be able to provide services to their patients regardless of where they're at.
Hey, Becky.
Yeah.
Before you move on, Robin, do you have a question?
Oh.
I see a hand raised. Maybe it's an accident. Okay. Just checking, but
nope.
Good job.
In. I'm happy to answer questions throughout, and I'm not paying attention to the chat. So
yeah. Okay. Sorry.
Yeah. So, and then now we hear this care from home. We're hearing this. We're hearing also the culture is changing. Telehealth first. During COVID, many patients were encouraged to do a virtual visit with their providers, and again, COVID brought this to the forefront. For so many of us, I had experienced a telehealth visit before. I happened to get chronic sinus infections, and it was on a weekend, or I was getting ready to travel. So through my insurance company, I used an app, but I saw a provider that I'd never seen before and probably will never ever see again in my life. With this culture now of video first or telehealth first, I've been able to see multiple providers that are my normal doctors over video to discuss follow-ups of labs, to talk about, a visit where we were just going to have a conversation, and it really didn't make sense for me to travel. It's just really, it's been very eye-opening, and very rewarding for me as a patient and as a mom. Both my kids have had telehealth visits. I've done, care for my family, for my parents. They've had telehealth visits during the last couple of years. But this culture is really pervasive across all insurance companies. And we're seeing many more commercial entities getting into the market. So Anthem, and they had some on-demand services. There's an Anthem, I pick on them because they're my insurance company. They have a virtual care on-demand service is what they're calling their service now. And we see many stories from CVS and Walgreens offering video visits now. And Walmart they've changed the name of their service to Health Virtual Care. And I forgot to put Best Buy in here. So Best Buy now has a virtual service. So as we see all of these commercial or these large retail companies across the country going into telehealth and into this business, I become even more passionate about, at our local level, at our primary care level, at our genetic counselor level, at our neonatal exams, incorporating some type of a video so that we keep those patients and they don't get lost to us and to our healthcare organization from these retail companies. I'm sorry, I'm just having trouble with my buttons today. Okay. So if you're interested in starting a telegenetics program, Lori has so many resources that she can provide to you, and through the NCC with all of the genetics programs. But if you're hearing this for the first time, start small. Start with something that is very tangible, very low-hanging fruit, to meet with your patients via video. So that easy win, you're going to get patient satisfaction, you're going to get provider satisfaction, and you want to build on that particular success. I do a whole talk about the culture of telehealth, and it's one of my favorite ones. And we see a lot less hesitancy from providers, especially, and even from patients now that we've been through this pandemic. I'm a glass half full kind of person, or a silver lining kind of person. And I really see that one of the best things that came out of COVID is this increase in the adoption of telehealth, and in it removing a lot of barriers as far as reimbursement. So this is just a couple of slides from that talk that I wanted to share with you. If you guys haven't been delivering services via telehealth, but finding a telehealth champion in your organization and gathering a diversified team, because it takes a village to support a successful program. And make sure to reward your providers that are doing that hard work to change the way that they think about reaching out to their patients. And you, those of you that are representing patients or in advocate roles, reach out to your providers and ask them, hey, is this a possibility? And it helps to increase access to both folks in urban and rural areas, to be able to connect with their providers on a much easier level. So this is my policy part of this discussion, and I so appreciate it. I don't know if Megan Lyon is still on. I so appreciated all of the policy stuff that you were talking about through the NCC. For telehealth, and I know it was mentioned, the different HRSA-funded genetic networks. So there's also HRSA-funded telehealth networks. And there's 12 across the nation. As Lori mentioned, I used to work for one of them that covered the upper Midwest, so Illinois, Indiana, Michigan, and Ohio. But there is a national policy center for telehealth that is one of the 14 telehealth resource centers. So this is a snapshot from the Center for Connected Health Policy, and you see their website there on the bottom of the screen. And they look at telehealth policy all across the nation. They focus on Medicare and then Medicaid. Just last week, they came out with their spring 2020 Medicaid summary chart. And if you've been familiar with telehealth for a long time, you'll notice that there's a lot more detail in this. And I just got a screen grab that had the most of the states for the Heartland Genetics Network. But again, there's the URL where you can find the full summary. And let's pick on Missouri. So if you look, Missouri has telehealth law for their Medicaid program for live video, for store and forward, for remote patient monitoring. They did not pay for audio only. They have a private payer law that exists. They do not have a payment parity, which so parity means that the law says if you cover it in person, you have to cover it via telehealth. The parity means you have to pay the same rate. And that's pretty normal to have a law for parity coverage, but not parity payment. And then they have, this is a new thing with this particular snapshot, they have all the professional interstate compacts. And we saw a ton of movement in compacts, physician compacts and nurse compacts and OT, so occupational therapy, physical therapy, EMS during the last couple of years, and then consent requirements. And that's pretty common to have consent requirements the patient has to sign to be seen via telehealth to allow that to happen. And this is just another snapshot from the Center for Connected Health Policy. So right now, we still have a federal public health emergency, and we're hearing that it's probably going to be renewed again in July. This particular bill, the 2022 Consolidated Appropriations Act, says that at the end of the public health emergency, for an additional 151 days, all of the myriad of policies that have been waived or opened up, the geographic barriers for Medicare, they are all still going to be in effect for 151 days after the end of the public health emergency. So this will get us 151 days. This will get us into 2023 from July. So if we do extend the public health emergency another 90 days, that's been the typical time frame, then this will get us, into the first quarter, if not into the second quarter of 2023, with all of these COVID waivers on policy and reimbursement. This is usually when we do the in-person training where I hand it over to Lori. And she says, okay, so for geneticists, but I think Megan did a great job of talking about policy. I know there is still when you look at policy and what providers are covered under telehealth at the national level for Medicare, geneticists and genetic counselors are still not covered. But I hope to hear some good news about that soon. That's the end of my slides. So I'm happy to take questions. Lori, did you want to say anything about Medicare coverage or licensure?
Thank you so much, Becky. Yeah, I failed to get you that update because I was ill early part of this week. No, we will update our states once I know exactly what is going to be introduced in the next Congress. So what Becky's asking me about is one of the challenges right now around access and equitable access for Medicare beneficiaries to genetic counseling services is that genetic counselors are not recognized by CMS as a healthcare provider. And therefore that limits their access to genetic counseling, particularly in the cancer realm. And but because we are not recognized as providers by CMS, we did not fall under a lot of the telehealth billing opportunities and things like that came about with the pandemic and the government sort of stepping in and relaxing some of the restrictions around telehealth access and increased access for patients of some types of providers, but not for patients of genetic counselors. And so that's what Becky was asking me about. And so I do not have the latest update. Again, that simply because I was ill for half the week. So I didn't get that task done, but we can provide our constituents an update with that. Any questions for Becky? I appreciated those policy updates, Becky. I didn't know about that extension of the 151 days past the end of the pandemic. So that's very helpful for our providers to know about. Kara, any other questions? Chat. Okay. Well, hearing none, and we're going to have more about telehealth. You know, telehealth is here to stay, as you all know. So we are going to be hearing more about that in our part 2 of our 2022 annual meeting. And in fact, I'll just make a note to say right now that our program evaluator, Dr. Barb Jackson, she has interviewed now at least one individual, if not more than that, of each of our medical genetics centers in the Heartland to learn about plans going forward for telehealth, what the needs are, and she'll be presenting that work to you at our next meeting so that we know how best to support telehealth in our region, both to maintain it and to continue to expand it. So more to come on that. Our final speaker today, guest speaker today, it is a pleasure to introduce Sophie Griffith. So Sophie, as Ann mentioned earlier today, is a brand new graduate of the University of Oklahoma Health Science Center's Genetic Counseling Program. And I had the privilege of getting to know Sophie a little bit. I served on her thesis committee, and her work is relevant to the work that Heartland is doing with the Hispanic population. I found her work to be fascinating. Sophie was a good writer. She was an astute student. She embraced this project, is very passionate about this project. And I thoroughly enjoy Marianne Kaufman attended her thesis defense, of course, as did I as a committee member. And she just did a tremendous job. So it's a pleasure to introduce her. And I think that you will enjoy hearing about her work. It's a first step in a project. And she has a student, a peer who's coming behind her in the cohort behind her, who will be taking this project sort of the next lap. So we look forward to seeing this project continue to grow and inform our work. So Sophie.
Thanks so much for the introduction, Lori. I'm just gonna start sharing my slides. It still takes me a moment sometimes. Let's see. There we go. Okay. Awesome. Can everybody see that okay? Great. So as Lori mentioned, I'm going to present a little bit about my thesis project. The first part was a lot of the information I think this audience already knows about some barriers to care in this region of the country. So I'm going to focus a lot on the second part, which was about acceptability of a chatbot for cancer genetic screening in Hispanic populations in our region. And so to start with a little bit of background, I kind of outlined our little Heartland states here with my black marker, but the Hispanic population growth rates have been the highest in states like ours that did not historically have large Hispanic populations. And so you can see in this dark green, there's been 50% or more growth in a lot of counties in our states. And with that in mind, we have a very rapidly growing population. It's the second largest ethnic group in the US. But because we haven't historically had a large Hispanic population here in this region, we don't exactly have as many resources to address their growing needs as, say, Texas or California. And so I apologize for the lawn work going on in the background. It did not, I don't know, they always choose the worst times. But anyway, the leading cause of death for Hispanic adults is actually cancer, which is interesting in that heart disease is the leading cause of death for pretty much every other ethnic group in the US. And cancer death rate has declined in other racial and ethnic groups, even though it stayed consistently high in Hispanic adults, which begs the question of why. And so some ways it's decreased in other groups has been through increased education about factors like not smoking, innovations in cancer treatment, and also early detection and prevention of cancer. This becomes especially important when we're looking at Hispanic adults because they tend to be diagnosed at younger ages. The median age of a cancer diagnosis for Hispanic adults is 30 compared to non-Hispanic whites where it's 40. And there's also a higher risk of advanced stage diagnosis in Hispanic adults than non-Hispanic white Americans. Something I didn't learn until I started this project is Hispanic adults are actually the second most prevalent carriers of BRCA1 and 2 mutations after Ashkenazi Jewish adults. So I think in genetics, we hear a lot about like Ashkenazi Jewish founder mutations when we don't hear the same information about Hispanic adults despite the high carrier frequency. And so even though age of diagnosis is young, advanced stage diagnosis is a higher risk, and there's a high carrier rate of BRCA1 and 2 mutations, awareness of genetic counseling and testing in Hispanic adults remains low. And so what we do in cancer genetics can really help reduce cancer morbidity and mortality because we can identify these folks that are younger with advanced stage diagnoses and help connect them with enhanced screening. And so in genetics, we really kind of work with these two groups mostly, this 10 to 15% of folks whose cancer is hereditary, so caused by a change in a gene like BRCA1 or 2, and the 5 to 15% of folks where the cancer is familial, so it's running in their family, but there's not necessarily an identifiable genetic cause. And so this is 15 to 30% of people that we could be reaching that we're not yet reaching. And part of the reason why is genetic services are limited. This is a general phenomenon. The shortage of genetic counselors is expected to last until 2024 or even 2030, depending on how many new graduates there are. Genetic services are even more limited in Spanish. So some Hispanic adults do prefer to speak Spanish. But per the Genetic Counseling Professional Status Survey, only 4.16% of genetic counselors actually speak Spanish, and not all these counselors are patient-facing. In our region, in the Heartland states, a directory of cancer genetic counselors just identified 2 Spanish-speaking patient-facing cancer genetic counselors. And so with this rapidly growing population, we're kind of strapped for resources to serve the needs of folks who do prefer to get health information in Spanish. You might be wondering, okay, what about interpretation services? The availability, despite the fact that it is required for Medicare-funded facilities, and the quality of available interpretation services is sometimes questionable per some of the research that's been done. So that's why it's great that Heartland is doing lots of interpreter trainings. So what we think, if we're strapped for resources, we're strapped for genetic counselors who can deliver bilingual services, How can we meet the needs of this growing population when we don't really have enough of us to try to help? And so alternative service delivery models are one way we can potentially expand the reach of cancer genetic counseling to underserved populations. Telegenetics, as we discussed previously, is actually one growing method. And a colleague of mine found that there's no difference in satisfaction with a telegenetics cancer genetic counseling session and a traditional in-person cancer genetic counseling session for Hispanic adults. Pre-test educational tools like Heartland's videos, there's similar ones being developed for cancer genetics, have been found useful and well-liked amongst Hispanic adults for delivering that necessary pre-test education. And then there are healthcare chatbots that are being developed. I'm going to talk about one called GIA, but there's a number of these innovations that I will go into a little bit more. And so what is GIA? It's an artificial intelligence chatbot that interacts with users in kind of a text message or WhatsApp-like style. I'm going to see, this video has been finicky, but I'm going to see if it will play for me. And so you can see there's kind of little text messages, like kind of, again, you'd see in a texting app. And you can message GIA, and GIA, the chatbot, will text you back. And sort of, even though it's like you're talking to a person, but you're not talking to a person. And so, oh goodness, the video might keep playing. It was developed and validated by genetic counselors. It's accessible on any smart device, so including smartphones, which is important for considering Hispanic American populations, which have comparable smartphone ownership to other ethnic groups. And actually 25% of Hispanic adults are smartphone-only internet users. And so they only use smartphones relative to computers to access the internet. And so chatbots like GIA are deliverable to cell phones, and they're also available in English or Spanish. So participants can choose their preferred language. In a previous study looking at this innovation, this was a very different cohort. It was mostly older adults, 60s, 70s in Pennsylvania in a rural area. They were almost all white, but they did like GIA, even though they were older, which I think is a lot of people might think older adults would not like technology. I don't think I need to impress upon this group that community leaders are essential for bringing innovations in healthcare to Hispanic communities. Again, I think we all know community leaders are essential for opening communication. They're trusted by community members. They have lots of credibility, and they also know who in their community can best benefit from certain services or certain pieces of information about ongoing projects. And so how does this kind of tie into this work? It's really important that when we're looking at novel innovations in healthcare, that we consider underrepresented groups in research, because we want to implement this technology equitably. And we also want to make sure people actually find it useful. Like from my theory perspective, I might think, wow, this sounds great. But if people in the communities don't actually like it, then it's not going to be good. Also, nothing about us without us. As a white woman, I don't have much say on this topic. And so I really need to reach out to the communities. I worked with some wonderful Hispanic community leaders to again see, is this necessary? What should I be considering when we're thinking about implementing a technology like this? And so these were some of my study aims. I'm really going to focus on 3 in this presentation, which was evaluating the acceptability of a chatbot like GIA amongst regional Hispanic community leaders. And so just to kind of briefly show you some of the findings from the first 2 parts of my project, I did want to see what are barriers to care specifically for cancer genetic service access in this region, because it's been studied in major cities and other regions and in pediatrics in our region, but there was kind of that gap for cancer genetics. And we actually found that documentation status was the largest barrier to care for our populations, which was not the finding in major cities and other places. So glad that we kind of looked into this. And then also I wanted to see the health education approaches that regional community leaders use. What are some important factors to consider when reaching out to communities and collaborating with community leaders to provide actually effective, helpful information? And so again, I think this group's probably familiar with a lot of these points, but a personal touch is important. Going to communities instead of having them come to researchers or hospitals. Simple language, different languages, and lots of colors and visuals are some of the highlights. So to briefly kind of walk through my methods, I won't spend a lot of time on this, but I did reach out to Hispanic adults with a leadership role in their community. So I got to talk with a lot of translators, public health professionals, parent resource coordinators, people who engage with a lot of community members and know their communities well. My Spanish is not good enough to interview people in Spanish, so I did need people who are at least bilingual and who could read English or Spanish or have someone help them read English or Spanish, because the chatbot is that text message style. We did personal contact recruiting because it's very important for building trust and enhancing the credibility of the project. Actually works better than a lot of traditional recruitment methods. And Mary Ann kindly helped recruit people for us. And two of the participants she recruited some of our other participants in kind of a snowball sampling method. And so the way this study was structured is I did interviews. I really wanted to get in-depth information about the topics that I was looking at. And so there was an interview before the chatbot that unveiled some of the themes I showed you before. And then I gave folks the chatbot, they got to walk through it, kind of play with the different features. And then I interviewed them afterwards saying, what did you think? Do you think this is useful, kind of thing? These interviews were done over Zoom because of COVID. And that's how I developed my questions. This is kind of a new topic area. So I had to synthesize a lot of existing research from different pieces, including some research that was associated with Heartland about access to pediatric genetic counseling here. We coded transcripts for themes. We used grounded theory. I used a 50% thematic threshold though, because we had a small sample, which I'll show in a moment. And so for our demographics, we tended to have younger folks than the existing study on chatbots, which is exciting to get a different perspective. All my participants were female. Preferred language was Spanish. We had different levels of education. I'm really proud of the different countries of origin. I recognize community leaders are not spokespeople for their entire countries. And at the same time, it's nice to have different countries' perspectives kind of represented in little ways because there's so much heterogeneity in Hispanic communities. Participant characteristics, we asked a couple different questions. The sample size, I would say, is not large enough to draw conclusions about features like acculturation, which we asked about through frequency of visits to country of origin. But we did see that most people weren't really familiar with chatbots. And kind of an interesting point, even though Spanish was the preferred language of everybody, most people actually completed the chatbot in English. And some of the reasons that were given were, especially because we had a couple translators, that some people were saying, we don't really trust the Spanish translation of things sometimes because it's not high quality. One person said it's good practice. And then I think possibly user error. I did send the chatbot by default in English. And so I don't know if people knew they could change the language necessarily. So just some notes about that. But the interesting part, we got a couple key themes from these interviews, overall impressions, the critiques, and how to implement this innovation in communities. And so some overall impressions, everybody really liked it. And that was kind of a surprise to me because I had a lot of folks in the first interview say, I don't want to talk to a robot, like I want to talk to a person, but every single participant liked it and almost everybody said it was easy to use. Participant 3 noted it was easy. I didn't see any glitches. The link just takes you right to the chat, so it was easy to connect. And then she said it was kind of like those pop-up chats we get from Home Depot or Amazon. It's easy, fast, and convenient per participant 6. And then participant 2 said, I'm so used to WhatsApp, I didn't find anything confusing. I read the directions and it said, you know, your options at the bottom, so I knew exactly where to go. Interestingly too, most participants said that talking to this chatbot was not very different from talking to a real person, and people actually would not have given different answers to a real person. And so there was a degree of trust, and I was surprised again with the personalism that's important with these communities that talking to a robot wasn't very different. Participant 7 said, you know, it was right on the dot. You answer it right away and you get an answer. It's relevant and it's accurate. And I mean, it's really easy to use. I was very surprised. And then participant 8 said, let's say it was like talking to a real person. It was straight to the point. The questions were very clear and I like it. A couple other folks said they actually felt more comfortable talking to this chatbot because they felt like they were less likely to be judged when giving it cancer health history or other personal information. Of course, a lot of folks said that GIA being offered in Spanish is a beneficial option. Participant 7 said, you know, I think it's a great thing because the link will go back to the language barrier. That's an obstacle that's like, okay, that's not an obstacle here. You can still do it even if you don't speak English. Participant 3, who is an interpreter, said, for the client, they don't have to pay more money for an interpreter. I mean, it's good for me that I have a job, but realistically, it's going to be good for clinics if they actually have clients pre-check in and give their health information to this chatbot before an appointment. And then another community leader said, and this is one of the community leaders who did GIA in Spanish, she said, even though she's bilingual, I have medical training, I'm a public health educator, if I have to pick and choose, I will pick Spanish because it's my first language. I feel more comfortable reading it. And if we're going to offer this, I'm here to represent the Latino community. A lot of participants brought up time features, that it saved them time. They liked being able to do it on their own time, and they could do it at their own pace. Participant 7 loved taking her time. She liked that it would make the doctor's office visit shorter because as the genetic counselor, I don't have to ask you questions if Gia already asked you questions. And she liked, you know, being able to call her mom and ask, what was my family health history, who had cancer before, and do that before the appointment. Participant 6 had 4 kids, and she says the time was perfect. She was able to incorporate it into her busy schedule. And participant 4 liked being able to take her time. She said, I sat down yesterday and I knew I was going to do that, and I got ready. She also talked about not feeling rushed. The chatbot doesn't make her feel rushed. And she was talking about how at the doctor, sometimes they do make you feel rushed. And so this didn't have that same pressure with it. I was surprised to see that most people said GIA was easy to understand. Participant 6 said every question was clear. The genetics explanations were clear. Questions were short and right to the point. Very simple, very easy to understand. And then participant 1 talked about how, I forgot to use the Spanish version, but in English, the literacy level was appropriate. This was actually different from the other study on GIA where people worried, what if my phone gets stolen or my email gets hacked? Half of our participants said GIA actually felt pretty safe and private to them. Participant 1 talked about the HIPAA compliance statement at the beginning was really reassuring to her as a medical professional. And at the end, in more plain language, the chatbot does tell you, don't disclose personal information in sort of a free text box that you can send to your healthcare provider. And then participant 4, instead of talking about information safety, also talked about physical safety. And so we know with this population, sometimes there's concerns about leaving a familiar neighborhood, going to hospitals or clinical sites. And so participant 4 said, I felt really safe and comfortable at home doing this at home. And so there's a thought you could pair something like GIA with a telehealth visit and ensure people are in a comfortable environment at their home instead of having to travel to a clinic, use gas money, take time off work. So those were some of the overall impressions. I do have a few critiques that came up in the interviews. Interestingly, there was only one I could get half of participants to agree on, but I did pick up on a few that I felt were helpful comments, even if they were made by 1 or 2 people. And perhaps unsurprisingly, the one majority critique was that some of the medical and genetics terminology the chatbot uses could be too advanced for some users. And so participant 4 talks about how this cancer chatbot does ask about types of cancer in the family, pancreatic, liver, left breast, right breast, triple negative. And even though it does have a little explanation near it, she said in her experience, when she talks about the liver and the pancreas and diabetes, people look at her like she's not sure they're understanding. People know that we have those organs, but they don't know where we're located and everything's in the stomach. Of note, the chatbot does make you pick a location for the cancer. And as genetic counselors, that can definitely change the assessment that we do. Participant 5 talked about the ADN, DNA portion being a little bit confusing. And then participant 1 said some of the levels of the definitions are too high. And you can click on certain terms on the chatbot to try and clarify it, But she did say for some people, even like clicking on those terms, the definition is still a little bit too advanced in some areas. More colors and visuals could increase appeal with Hispanic communities. The chatbot's very like blue and gray and white. And so participant 2 talked about, well, when you're talking about cells and genes, if you just add a little bit of color and match the words genes, DNA to different colors, you could separate right away which parts are which. Participant 5 talked about adding more pictures for lower literacy levels, especially because folks in the Hispanic community are becoming more familiar with emojis, and she really liked the emojis. And it can help check if patients are satisfied or not, and is also easier for families that don't have high levels of reading skills. And then these were one-off comments, but 2 very important ones. There's actually one typo in the Spanish translation of GIA. It is trying to say, what is your height, but it accidentally asks, what is your age? And so we all know that typos can impact credibility of a resource. And so it's important to go back and fix that. We've talked about potentially letting the developers of GIA know about that. And then at the end, GIA does ask you to pick your insurance if you're qualified for genetic counseling visit and genetic testing. And there apparently is no uninsured option, which we know can be a problem for regional Hispanic and Latinx communities, because there are a lot of folks who are immigrants per participant 1, and they cannot afford to pay for insurance. And so kind of an oversight for something like this that could address a lot of barriers, but there's some pieces like this that should be fixed first. And interestingly, this wasn't really a theme when I was developing my questions, but the community leaders were very excited about the potential to implement a technology like GIA. And so I got a lot of recommendations from folks about some good strategies for implementing it. And so most people did say a trusted individual to walk people through a chatbot like this could increase uptake amongst people less comfortable with technology. And so participant 3 said, I think many families will take it in a good way, but many families will take it as a challenge because it's working with electronics. So they are going to rely on someone else to help them out. Participant 6 talked about acculturation and immigration and saying some recent immigrants don't trust technology that well. And also generations. She did bring up different generations, maybe more or less comfortable with tech, but she's like, you could do a meeting in person, have a real person explain to them it's safe, and that the health information they put in is not being shared. Also adding a more personal touch. Participant 6 gave the example of before sending the chatbot, like when I did interviews with folks, I told them I'd send a link. She's saying you could give them a call and say, hi, how are you? And that, you know, people miss that, especially with COVID and everyone being isolated. But you could say, you know, hi, my name's Sophie. You're going to get a link from me that has this assessment, to try and personalize it a little bit more. And so this is, I'm not going to read this all out to you, but just a quote from one participant where it kind of illustrates to me that GIA could be helpful for cancer screening in regional communities because it's easy to get, it's easy to navigate, takes 15 minutes if you just do it regularly without exploring all the little different options. And it could make folks aware of how cancer could run in their families. The chatbot does collect a family history, and it looks at NCCN guidelines, and it says, you know, if you could benefit from cancer screening or a cancer genetic counseling appointment. And so participant 2 talks about like, it could be a good way to get a screening to see if I need to go to the doctor. And so just to summarize kind of what I've talked about, everyone would recommend it because it's easy to use. It's not different from talking to a real person. The language barrier is not an issue here. Saves time in a lot of ways, and it's pretty safe, private, and easy to understand. I just kind of pulled some of the findings from the barriers and put on the right side some ways that chatbots like GIA could address some of these top barriers to care in our region. For example, with documentation status being a big barrier, GIA is free. It doesn't really assess documentation status. And we could pair it with the PAP or patient assistance program with certain labs that'll offer free testing for people under pretty generous income thresholds. And it does not check for documentation status. So these labs can offer free testing if you qualify based on income, regardless of documentation status. Language barriers, again, not an issue. income and insurance, as I talked about, we can pair it with free testing. GIA basically covers pre-test genetic counseling. And so really a system like this could be used to screen people who only need post-test genetic counseling, if that makes sense. And so we save people from paying a pre-test genetic counseling fee and possibly a genetic testing fee. Competing priorities, a lot of folks are busy. Families have a lot going on and they want to make sure their family is fed and taken care of. This doesn't require people to take time off work. It doesn't require people to spend money, can be done whenever. And I mean, lots more issues that are sort of addressed by something like this. It also kind of incorporates some of the health education approaches I learned about from regional community leaders. It's self-paced. It's not different from talking to a real person. It can be done in a community setting. I had a couple community leaders talk to me about, like, you could have a presentation in the community and you could have someone walk people through it at a community site. It does incorporate different languages and some colors and visuals, and it's in, again, a familiar format like WhatsApp or texting that could be an approachable way to deliver cancer screening. And so just some practice implications. A tool like this could help genetics providers reach underserved populations in a culturally friendly and resource-friendly manner. It doesn't require bilingual genetic counselors or more interpreters. In terms of marketing it, emphasizing it's free, it's private, schedule-friendly, features like that. I think it's important as genetics providers that we educate communities on documentation-friendly cancer genetic testing. I had a lot of folks bring up families want genetic testing, they want cancer education, but they think it's too expensive, or they're worried about documentation status and privacy. And so I think it's on us as genetics professionals to say there are ways for you to get genetic testing that won't check documentation status, that can be free for most incomes. Also, I think it's important to pair this with free screening resources, information about Medicaid in case people need treatment, because it's not necessarily cool to tell someone, hey, you have a mutation, good luck. It's on us to also ensure people can get appropriate screening and follow-up and treatment. Cost transparency about post-test genetic counseling for people who are flagged by the chatbot as having potentially a genetic risk and they test positive on genetic testing. It would be important to have discussions about post-test genetic counseling possibly coming with a cost. I've talked with Darcy, who's my committee chair, about ways we could reduce this, but it is a work in progress. And then finally, emphasizing family health rather than individual health. A lot of community leaders brought up to me that the well-being of the family and the importance of the family culturally is very important. And cancer genetics are fundamentally a family concern. Someone having a pathogenic variant could pass that on to their kids. And so the health of the whole family is involved rather than just an individual. And just some conclusions, we were really the first to look at acceptability of a chatbot for cancer in Hispanic populations anywhere. We happened to look at Oklahoma and Nebraska, but yeah, this research hasn't been done on Hispanic populations or really any non-white populations at all, despite genetic counselors saying, let's use this for everybody to address barriers. We're also the first to look at cancer genetics barriers in this region, which is exciting. Hopefully can inform a little bit of outreach. I don't know if I have it on the next slide. Yes, my colleague Mackenzie is going to look at community members. I looked at community leaders, but sometimes community members don't have the same educational attainment as community leaders, and that can impact preferred information source. There could also be lower literacy. Literacy is a big barrier in this region in particular. And this is a text-based chatbot. And so maybe we could add text to voice features, but it's important to consider Hispanic community members could have different opinions than Hispanic community leaders. And so looking at more groups, doing some outreach and education about cancer prevention is clearly needed. And a larger sample, these communities are very heterogeneous. I gotta see if I'm okay on time, but I would love to address any questions here, or if you'd like to email me any questions. And I thank you all for your attention. This is like the first big presentation I've ever given, so thank you.
And she just graduated, so yeah, you're on a pretty good trajectory there, Sophie. Thank you very much. And thank you for tailoring your research project for this audience and this presentation or this conference today. I want to be mindful of our time, but I do want to give Sophie a chance if there are any questions.
If no one else is raising their hand, I can. Is anyone else raising their hand? I'll give them.
I know, Marianne, I'm biting my tongue too, so.
Yeah.
Go ahead, Marianne.
I just want to say excellent, excellent presentation, Sophie. Congratulations on your MS. I noticed that after your name, big accomplishment. Just three quick things I'm going to mention, because a lot of the stuff that you brought up are things that we deal with in the production of our videos. The first thing is a special touch. I think we're finding that in our videos, that people will watch the videos if it's promoted by someone they trust. Again, back to the relationship. One thing I do want to bring up is the Spanglish thing, is that yes, most likely community leaders are bilingual, and not only bilingual, but bicultural. I noticed that in my work, when I'm working with community leaders, we switch back in language quite a lot. And sometimes we speak only in English when it comes to new knowledge and technology, which might be why they want to use the English version versus the Spanish version. So I think that's very important. 80% of the Latino community are either English speakers or bilingual. And so, as you said, the literacy level, the understanding of language, the processing, what language they use for what task varies. And so that's something that we as researchers have to always consider. They may say they prefer to speak Spanish, but they may want to write English because they went to school learning to write English and read English. So I think as we do our research, that is something that we always have to consider. And the idea is options. I also agree with you that once you talk to the members, to the community itself and not the leaders, is that we will show maybe lower literacy levels, and we have to choose our tools and how we communicate with them. And fear is real, by the way, especially for new Latinos that come to this country. And we always have to keep that in mind regarding lack of documentation. Anyway, that's it. Excellent job, Sophie. The best to you as always.
Thank you so much, Marianne, and thank you for the insight. I really appreciate your perspective because I hadn't considered those interpretations of the data before. So thank you.
Yeah, you're very welcome. Thank you.
So I have one question, Sophie. I was hoping that our Invite rep from for this region would be on at our meeting today, but I didn't personally invite her. So are you going to reach out to Invite about the misspelling, the misinterpretation of that word?
Yes, Darcy and I are figuring out the specific process for doing that in terms of like, do we want to wait till we have a publication versus my 128-page thesis? But yes, we want to reach out to Invite about like all this feedback. I think it's all valuable information for them to have as they consider iterations of this chatbot, especially also the comments about visuals, like maybe we could add more videos to Gia. So definitely, yes, we're trying to figure out how to do it, but yes.
Well, I have an idea we can talk about offline, because I'd like to see that just get fixed without sharing all your data. And I think I have a way to do that. So we can talk about that offline. Okay.
Thank you.
All right. You're welcome. All right. So if Melissa, if you can put up that last slide. Well, maybe not the last slide. Okay. What's coming down the pipeline? Well, before I go through this list, I want to just take a moment and thank, I know we'll do this again at the end, but I just have to thank these speakers. Oh my gosh, this morning has just flown by. The topics were so interesting, so relevant, and I'm just so grateful to everyone who's put in so much. So I just want to give everyone a round of applause right now. So what is coming down the pipeline? As I mentioned earlier, we have two more years left in this current funding cycle. And so this is kind of a boring slide, but I'm just going to run through it as quickly as I can and try to make it somewhat interesting. So you've been hearing a lot today about different products and materials. So we have a plan for continuing to develop more products and materials. Now, all of these products and materials, just so you know, and so our funders know, are all based on our on needs, on work, information coming out of the communities, information coming out of our work groups. All of our products and materials right now, the focus is making sure that everything we develop is available in English, in Spanish, and in Marshallese. Okay. There have been a growing number of requests to have our products and materials available in other languages. And so we will be addressing that with our advisory board as well. But I just want you to know, at least for what we have planned in this next year, at least, we will make sure it's available in those 3 languages. Now, oops, just one second. Get back to my notes. Anne has mentioned the Care Notebook app. That was developed this year. That's why Anne had mentioned it as one of our products. And she said, you know, it's going to be launched once we have our social media piece sort of up and running. So I'll talk about social media presence in just a moment, but know that the app, the Care Notebook app, it is available. So if you have an Apple phone, it's in the Apple Store. It's also for the Android on Google Play. It is called the Heartland Care Notebook. Our big launch and advertisement and getting it into communities will occur here in the early June. It's sitting there. We're just waiting on a couple other things, not with the app itself, but with the social media piece. And then it is going out there. So be looking for that, but it's already available if you would like to go in and go ahead and download it. We are also developing, it started out being called a microsite. It was going to be a standalone site. Right for the moment, it is going to be a complete overhaul and enhancement of our education, of our resources on our website. I think next year it will move to a standalone microsite as an educational hub. I am very excited about this. Aaron Beaver has led this project. We are trying to fill in gaps where there are educational resources lacking, what we've learned from our patients and our families that we work with through Heartland. And we will continue to build out this product, but right now, of the outline that we made of the categories that needed to be, you know, have some information available, we have at least one resource in each of those. And like I said, over the summer, we have a lot more that we are finishing up to add. So that will also be launched in the next couple of weeks. It's going to be a lot happening, let me tell you. The IHP, Individualized Health Plan Project. So Anne had already mentioned that. Yes, we have our advocate work group has worked on that. We have information available for families. We did that training with our advocate work group. But what we'll be doing in the next year is actually going out into, you know, with the family networks would like to train their staff about IHP so that they can talk to families and understand more in depth about it. If you know, any support network, any support group wants to have a training on that, we will be offering those and developing the video testimonials. What's happening with telehealth as a product or resources? Well, that we'll learn. Dr. Jackson will have data for us. As I mentioned a moment ago, she had collected interview data from all of our medical genetics centers in the Heartland region. And she's in the midst of processing that data now and looking for themes and to make recommendations. What about, so we've gone out to these communities, we do our best to listen and learn and develop in response some resources and tools. But one of the things I always tell the communities with which I have worked is, yes, we want to increase awareness and give you, help you understand what genetics is about, and how you can access this and all that. But we fail if we do not then take the information we have learned from the communities back to our genetics providers. Because I tell the communities, part of what we want to learn from you so that we can do our job better. Okay. And so this next year, we're going to be doing a concerted effort around trainings and resources for genetics providers. Because if the small staff within Heartland and our project coordinators that have worked with these communities, and we learn all this information and we think it's all so exciting and interesting, but we don't convey that information that we have learned with our providers, then nothing's going to change. The quality of genetic services, if a person, they may access the service, they may be aware of it now that maybe they weren't aware of before. They make it to genetics because there's been a determination that they need a genetics appointment, that they get there and that genetics provider in the Heartland region doesn't know about their culture or about, some very basic practices that they could do to help that patient along the way and be respectful around their culture, or at least know something about that. Well, we've got to do that part of the work. And so there's going to be some real intentional effort around that this next year. And Anne has already mentioned the ECHO series. So what about social media? So I want to see a raise or show of hands. Who noticed anything new on the very first slide today? Anyone notice anything new on the very first slide we had up today? I'm not seeing any hands raised. Okay, well, we have been working with the company actually that produces our videos, and they are helping us finally with our social media presence, our coordinating our communication. And so we are in the final stages of phase 1 of all of that work. And so that's why we're waiting on some of these things. We want people to recognize the, Heartland brand, if you will, and have all of these launches of these products done in a way that is coordinated and in a way that is inviting and enticing, and people will look at it and be interested in it and engage with it. So we'll be having a fresh look. We'll also be offering regular educational posts, and I've already mentioned the coordinated communication. So what about partnerships in the coming year? Well, we continue to learn every single time I make a trip to go into a community, or I talk with Marianne today. I just learned something from Marianne and Sophie. In that talk, every single time we learn. And then when we listen and we learn from the community, they tell us who we need to be partnering with. So we have partnerships now beginning to grow with federally qualified health centers. So if we follow where the community leads, and Mariana mentioned this in her talk, they will tell you who are the health providers you need to work with, And then we partner with those health providers. And that is going to go back to Maria Castillo's early question around dissemination. How do you actually get this into, how do you get these materials into the community? So we're going to be working on that. We always want to evaluate our work and not just, you know, pat ourselves on the back and think we've done a good job. We need to really look critically at it because we can always improve. I mean, who cannot, right? So we can always improve. There's always something to learn. And so we'll be continuing with different types of evaluation. In our part 2 of our annual meeting, you will hear about a massive effort to evaluate the videos in Spanish that have been developed. And so I mentioned dissemination. We hear these words all the time: evaluation, implementation, dissemination. Okay, well, the dissemination is critical. Otherwise, all this stuff, instead of, you know, sitting on a bookshelf, was the old phrase, just hanging out in cyberspace. We want people to be using these materials and giving feedback and, you know, applying this information. So figuring out where and how best to disseminate, that is going to take intention and paying attention to the communities. And I've already mentioned partnerships. I've mentioned, you know, new partnerships with new types of healthcare providers is one, and then some other efforts that have been done that have resulted in huge dissemination of some of the products. We will, because we work in academic medical centers, also be working on publication. I will tell you that some of the publications that we published a couple of years ago around the Hispanic Access Project and the taking a family health history with a Marshallese patient, those have generated quite a bit of interest. And we actually receive emails from around the country of people asking us questions because of those publications. And so publications are not simply, you know, a checkbox we have to do in academia. Those publications are actually helping to reach healthcare providers who then say, oh, they know something about the Marshallese population, or they've done work with the Hispanic population. So that has been helping get the word out there, you know, into communities as well. And then mentorship. You know, Sophie just presented, and we have a plan for really engaging. I've already started some baby steps toward that. We now have 5 genetic counseling training programs in our region, and we need to be involving those up and coming healthcare providers more in our work. And so we will be engaging with those genetic counseling programs more in this coming year. And so why all of this? Do we just do this because we have to report back to HRSA? No. You know, you all know me. Well, some of you don't know me, but if anyone knows me, you know, I don't check a box. I don't do something just to check the box. What we're trying to do with all of these collective efforts is clear the path, pave the way for increased awareness for members in these communities. You know, genetics is not going to be the most important thing in their world until it is, until that day when that baby's born, and now they need our services. Well, they need to know about the services so that they know how to, okay, this, you know, this type of help exists. So awareness, improving access, so you can know about it, but if you can't get to the service, then we have failed. So increasing awareness, improving access, and then that third piece that's so important is providers need to do a better job when those families show up in their clinic. And so we're trying to do all of these efforts to feed in to that ultimate mission of helping to improve the lives of individuals with genetic conditions and the lives of their families their health outcomes. And I will, so that's what's coming down the pipe. All right, I'm getting the time that it is up. Okay, 12:08. Sorry, Anne, thank you very much for letting me know. All right, part 2 of this meeting will take place September 21st, 22nd, and 23rd. Location is to be announced. We are soliciting bids from a few cities, but based on modeling by our local epidemiologist and Chow's husband, we think, hope, pray it will be safe to convene in September in person. Woohoo! And so that's why you're going to hear more about some of these talks and what the planning committee had recommended. I know we're over time, but I want to thank the planning committee again. Pat Fox, Aaron Beaver, Ashley Crowley, Graciela Sharif, Jennifer Basinger, Larry Weatherford, Marianne Kaufman, Joelle and Amy Burke. Thank you all very much. You convened quickly. You did your work incredibly well, given the caliber of the speakers that we had today. I just want to thank all of you. And I believe that Melissa has put in the chat a link for the evaluation. Please do fill that out. Carol will follow up with you as well. We want to get as much feedback as possible. I apologize for going over. I told them it was dangerous to have me close out the meeting because I'm a talker. All right. Thank you all very much for attending.
Yes, thank you.
Thank you.